Hello again, folks, and welcome to the next section. This is on assessment and treatment of voice disorders and medical and surgical management in otolaryngology. And this is from chapters 12 and 18 of the Johnson and Jacobson, and also a number of other supplementary sources that I've added. So let's get started with a little bit of a review on anatomy and physiology of the larynx. So first of all, the functions of the larynx include respiration, airway protection, and phonation in order of importance. So the most important function of the larynx is respiration, followed by airway protection, and then phonation. You should note that the larynx is not an anatomical site unto itself. Its functions largely dependent on the structures that are attached to and integrated with it. So the muscles and soft tissues of the neck, the trachea, the esophagus, the hyoid, and the mandibular bones, the tongue muscles, etc. So it is interconnected with all these other tissues. And so muscle tension, for example, in one area will affect the functioning of the larynx itself. The larynx is composed of multiple tissue types, so cartilages, muscles, nerves, and blood vessels. And let's start with the cartilages here. So we have in the larynx a number of cartilages and a bone. Here, some consider the hyoid bone, the structure here, as not being a part of the larynx proper, but it is attached to the larynx, superior of the larynx. And this is Greek for U-shaped, and the larynx is suspended from this bone. Then we have the thyroid cartilage, this large cartilage here with this notch. It's got superior and inferior horns on the posterior portion. And the posterior horn is attached to the cricoid cartilage here via this joint, the cricothyroid joint. And it rocks back and forth, and that allows for the vocal folds to stretch within. Thyroid is Greek for shield, since the structure looks somewhat like a shield. And then the cricoid is Greek for ring, because it looks somewhat like a signet or a class ring, being fatter kind of in the back than in the front. There are also the arytenoid cartilages, these kind of pyramidal type cartilages that sit on top of the cricoid. And each of these little arytenoids here has a muscular and a vocal process. So the vocal process is this anterior portion here to which the vocal fold is attached. So here's a few muscles there, and here's the vocal ligament. So the vocal process is the part that's attached to the vocal ligament, which is a part of the vocal fold. And we have a muscular process in the back, this little projection here, to which the some muscles of adduction and abduction are attached. We also have the epiglottis, this kind of leaf-shaped structure here that flips over to protect the airway during swallowing. There are also a few other cartilages, the corniculate cartilages, which are the superior tips of the arytenoids here. And we also have the cuneiform cartilages, which are not visible here, but kind of embedded in the aryepiglottic folds. And note that all of the cartilages in the larynx, with the exception of the epiglottis, are formed from hyaline cartilage. Hyaline cartilage ossifies, meaning it becomes more bone-like with age. The epiglottis, however, is formed from elastic cartilage, which does not ossify over time, and it's a lot more flexible. So this whole laryngeal structure will get stiffer, more bone-like with age. That's why when you have an older individual that goes into surgery, they have to use some relatively high-powered equipment in order to kind of cut through it, because it's basically, it feels like a bone in old age. Another note about the cricoarytenoid joint. So the arytenoids on top of the cricoid can rock and they can slide. So there's this axis here, this kind of a major axis on the posterior superior portion of the cricoid. So the arytenoids can slide on the major axis, and they can rock over this minor horizontal axis here. So meaning they have this sliding ability, and they're able to roll, meaning they have pitch. They're able to rotate about this axis here. So they're able to kind of rock back and forth, and they're able to slide. They don't really have much what's referred to as yaw, so they can't turn about a vertical axis. And they may have a little bit of roll, kind of rotation around this axis here, but not much, if any. So the primary motions of the arytenoids on the cricoid via the cricoarytenoid joint is to rock, or that's referred to as pitch, and then slide. So there's the rocking, and there's the sliding. There you can see it kind of wiggle a little bit. That's kind of the rocking motion. And you can see when they dissect it, it's got this kind of a concavity that would allow for rocking and sliding, but not much else. And here you see it rocking. And that would be adduction, and that would be abduction. And there's the sliding. Yeah, and these two movements occur simultaneously. And you can see when they remove the muscles and replace it with fibers that kind of simulate the action of the muscles. You can see the vocal folds adduct and abduct. Sorry, simulating the action of the posterior cricoarytenoid muscles. So abducting the vocal folds. The cricothyroid muscle is attached to the cricoid cartilage inferiorly and the thyroid cartilage superiorly. And so when this muscle contracts and shortens, it decreases this angle here. So this angle is made smaller. The vocal fold, which is attached to the thyroid cartilage anteriorly and the vocal process of the arytenoid posteriorly, it stretches given a contraction of the cricoid muscle. So you can see in this visual here, when this muscle gets shorter, this cartilage here kind of rocks back a little bit, thus making this vocal fold longer. Note that in this figure here, it's more the thyroid cartilage that is changing position. A contraction actually pulls the thyroid cartilage down a little bit. So this portion kind of goes forward a little bit, which is elongating the vocal fold here this way. And in actuality, both kind of happen. Really, because the cricoid cartilage is kind of attached to and anchored to the trachea, I'd say it's probably a little bit less mobile than the thyroid cartilage. So it's probably the thyroid that kind of meets the cricoid. But nonetheless, there is a decrease of this angle. And the net result is that this vocal fold gets longer when this muscle contracts. So low CT contraction, this is long. High CT contraction, this is short here, meaning that the vocal fold is long given CT contraction. Vocal fold is short given low CT contraction. A little review of a few intrinsic laryngeal muscles. So we've got two adductors, one abductor, and a couple of tensors. So adductors are muscles that act to functionally move the vocal folds closer together towards midline, closing off the airway. Abductors are muscles that functionally move the vocal folds apart, away from midline, opening the airway, right? And then tensors are muscles that act to functionally increase the tension of the vocal folds. So the adductors are the lateral cricoarytenoid and the interarytenoid. The abductor is the posterior cricoarytenoid, and the tensors are the cricothyroid and the thyroarytenoid muscle. So here's the thyroarytenoid muscle, and there's two bellies. There's a muscularis portion lateral and a vocalis portion medially. So the vocalis muscle, when it contracts, it's largely responsible for frequency modulation, shortening the vocal fold here and increasing tension within the body of the vocal fold. The muscularis portion, when this contracts, it actually has a slight adductory function. Then we have the lateral cricoarytenoids back here, the lateral to the muscular process of the arytenoid. When these contract, they cause adduction of the vocal folds. So you can see the motion here. So when these contract, the vocal fold processes come together at midline, closing off the airway, adducting the vocal folds. The interarytenoids, or the interarytenoids here, are in the back, and there are two portions. There's the transverse and the oblique portion. And the oblique portion kind of continues up just along the inferior portion of the area-epiglottic folds. And by the way, the cuneiform cartilages are embedded in this portion here. So corniculate and then cuneiform are kind of embedded in this region. So when the interarytenoids contract, they help close the posterior chink of the glottis. So the kind of the posterior portion that might be open a little bit, they help to close it. So there's a little gap here sometimes that is still present. Well, with the contraction of these muscles here help close up that posterior gap or chink. All right, then we have the posterior cricoarytenoids in the back here. And there's a mnemonic that I use to remember this, and it's, they're called the vocal folds now. They're not really cords because they are attached to the walls. And so therefore, anatomically, they're closer to folds than cords. But they used to be called in the older days, the vocal cords. So a mnemonic that I use is pulls cords apart. So abducting, they pull cords apart, PCA. But again, they're folds, not cords. Here's the action of the PCA muscle. So when this contracts, it causes the vocal folds to separate away from midline and the airway to open, abduction. All right, then we have some extrinsic muscles. By the way, intrinsic muscles are muscles that have their origin and their insertion within the larynx proper. Extrinsic muscles have one connection within the larynx and one connection outside of the larynx. So that's kind of the distinction there between intrinsic and extrinsic. So here are a few selected extrinsic muscles. We've got functionally, we have elevators, which raise the larynx, and depressors, which lower the larynx. So elevators include muscles like the stylohyoid, the mylohyoid, the hyoglossus, and the digastric. And then the depressors include muscles like the sternothyroid, the sternohyoid, the omohyoid, and the thyrohyoid. And a little note about muscle naming conventions for those that, if you may remember this from anatomy and physiology, when you have a muscle like this, where there are two structures, like the styloid process and the hyoid, for example, the first portion is the origin, the point which is less mobile, and the second naming portion here is the insertion, the point that is slightly more mobile. So for example, the stylohyoid is attached, the origin is in the styloid process, the insertion is into the hyoid bone, and so it pulls the hyoid towards the styloid process. So this kind of works for all of these muscles here to a certain extent, except for the digastric. The digastric has two bellies, and so it's kind of a descriptive term. Sternothyroid, it's attached, the origin is in the sternum, and it's attached to the thyroid, so it pulls the thyroid cartilage down towards the sternum, so thus depressing it. The sternohyoid, it's attached, the origin is in the sternum, it's attached to the hyoid, pulls the hyoid down to the sternum, etc. So that's just a note about naming conventions here. So here are some elevators. So we've got the hyoglossus, the genioglossus, the myohyoid, the digastric, geniohyoid, the stylohyoid, and the digastric posterior portion here. But these all functionally act to pull the larynx up. And so this is important for swallowing, for example, airway protection. And then we have laryngeal depressors, so muscles like the omohyoid, anterior and posterior portions, the sternohyoid, and the sternothyroid. And these are important for things like yawning. Right, a little note about innervation of the larynx. So the larynx is innervated via the 10th cranial nerve, also known as the vagus nerve. Vagus, it's the same root word as vagabond. So it's the wanderer. It's the longest nerve, cranial nerve in the body. And the branches that innervate the larynx are the superior laryngeal nerve and the recurrent laryngeal nerve. So the superior laryngeal nerve from above here, it's located superior of the larynx. And there's two portions. There's an internal and an external branch. The external branch provides motor innervation for the CT muscle. So it's only responsible for innervating the CT muscle. So it's involved in pitch modulation. Obviously, when the CT contracts, the vocal folds get longer and thinner. So they vibrate faster, so thus higher pitch. The internal branch of the superior laryngeal nerve is responsible for supraglottic sensation. Things like a gag reflex, for example, might be fed by this branch of the superior laryngeal nerve. The recurrent laryngeal nerve has got two bellies, external and internal. The external belly is responsible for all innervating all of the intrinsic laryngeal muscles except for the CT. So the lateral cricoarytenoid, the posterior cricoarytenoid, the interarytenoid, the TA muscle, it's responsible for all of those muscles. And it also is responsible for subglottic sensation as well. So the right recurrent laryngeal nerve loops around the subclavian artery, and the left recurrent laryngeal nerve loops under the arch of the aorta in the chest. So the left recurrent laryngeal nerve is actually slightly longer than the right one. And so there's a little bit of an asymmetry there in terms of the lengths, but they both come up from around those, looping around those arteries and insert into the larynx from below. So thus it's the recurrent laryngeal nerve. And these can be damaged in open heart surgery and thyroid surgery, like if you have a thyroid gland, concerns of thyroid cancer, for example. Anytime you have a chest or neck surgery, there can be a potential for nicking or stretching or damaging these nerves, and thus impairing vocal function. Little note about the histology of the vocal fold. So if we're looking at a coronal cross-section, so kind of separating the body into anterior and posterior portions, so that plane here, slicing it that way, we can kind of zoom in on the vocal folds here and look at its microstructure here. So the vocal folds have an epithelial layer, so kind of a skin layer, squamous, stratified squamous epithelium, so skin. And then there are 3 layers of lamina propria, a superficial, an intermediate, and a deep layer, and then a muscle. You can kind of see it schematicized here. So the epithelial skin layer, the superficial, intermediate, and deep layers of lamina propria, and then the muscle. So the epithelium is basically like skin. It's very, very thin. The superficial layer of lamina propria is also referred to as Reinke's space. It's mostly made out of, it's got interstitial fluid and sparsely populated elastin fibers, and it mostly acts like a cushion. The intermediate lamina propria layer is kind of a transitional layer, and it's got more elastin fibers, a little bit of collagen, but a lot of elastin fibers, so it's very elastic and stretchy. And then you have the deep layer of the lamina propria, which is mostly collagen. So this kind of prevents extension of the, prevents excessive extension of the vocal fold, excessive stretch. And then you've got the thyroarytenoid muscle deep within the vocal fold, which that's the vocalis muscle of the TA. And so you can see as we go from superficial to deep, the structure gets more dense, right? So we kind of start with more pliable stuff here, and then we get more and more dense. Also, anteriorly to posteriorly, we've got an anterior and a posterior macula flava, which is kind of a bit of kind of a nodule of connective tissue here. Not like a nodule, but it's kind of a bit of connective tissue. So it's stiffer here and stiffer there. They kind of act like shock absorbers. So it actually, posteriorly to anteriorly, there's a change in terms of the density and stiffness as well. So these are kind of anchor points. These are a little bit stiffer, and they kind of help. They prevent tearing at the edges here. So the anterior and the posterior macula flava kind of act as shock absorbers, and they give it a little bit of structural integrity. So continuing to look at the vocal fold in coronal cross-section, but now during phonation. So during phonation, there is a change in the glottal configuration. So during the opening phase, the glottis has a convergent shape, meaning the anterior or the superior portion is closer than the inferior portion. So it's got this convergent shape. When the vocal folds are maximally separated, during phonation, the glottis has a more rectangular or kind of a parallel shape. And during the closing phase, the glottis has a divergent shape, meaning that the inferior portion is closer. The inferior portion is closer together than the superior portion. So it's closer together there, further apart there. And so these different glottal configurations respond to different intraglottal pressures, actually. Sorry, it's slightly positive when there is a convergent shape, and it's slightly negative when there's a divergent shape. So you can see here, one cycle of phonation, we've got positive pressure here. That's contributing to pushing the vocal folds apart. Once the vocal folds are maximally separated, the elastic forces, the recoil forces of the vocal folds kind of take over, and these vocal folds want quote unquote, to return back to midline. And so they start to return back to midline. And it happens inferiorly first. So this portion kind of comes together first. And as airflow is continuing to come through here, because there is a narrow portion here, and following Bernoulli's law, when you have a constriction within a duct, and you have a constant flow volume through that duct, given a constriction, volume velocity is higher and pressure is lower. So anytime you have a constriction, you've got a lower pressure associated with it. So that higher velocity and lower pressure causes a kind of a suction pressure that, in addition to the elastic recoil, causes the vocal folds to kind of suck together a little bit. And so they suck together, and then there's closure. So here we're looking at a glottal flow pulse. So kind of looking at the volume of air as it passes through, or as it passes between the vocal folds during one glottal cycle, right? So it kind of increases and then decreases. It kind of shuts off during vocal fold vibration. So the gross positioning aspect of the vocal folds is referred to as adduction level. So you can have a vocal fold configuration that's fully open, so fully abducted, so during respiration, for example. And as these come together, there starts to be a little bit of phonation that occurs. So this is a breathy boundary. So going from to, so a little bit of phonation. And then as the vocal folds come closer together, there's kind of a normal breathy boundary that's crossed. And as they get closer together still, there's eventually kind of a pressed phonation. And then eventually the vocal folds get so close together that there can be no phonation. Basically, you're lifting a heavy weight at that point, right? So something you might do to increase abdominal pressure during like a deadlift, for example. So there's this whole phonatory adductory range that you have to be within in order for phonation to occur. All right, a note about frequency or pitch. So pitch is kind of the perceptual term, and frequency is the more objective acoustical term. So this relates to the vibration rate of the vocal folds, right? So when you have a high pitch or a high frequency, there's a lot of vibrations that occur in a given second, right? Well, what controls pitch? Primarily, it's stiffness and mass. This is kind of a simple equation for fundamental frequency. When you have a higher stiffness, so the vocal folds are stiff, maybe they're stretched, nice and taut, then because this is in the numerator, because this is in the top of the equation, when this gets big, this gets big. So when you've got a high stiffness, you're going to have a high frequency of vibration. Mass, on the other hand, that is on the bottom of the equation here. So when you've got a high mass, this is going to be low. So when you have a high mass, fundamental frequency is going to be low. So big mass, lower pitch, right? So thus, stiffness and mass are primary control variables for fundamental frequency. So a note about intensity and loudness. So intensity is the objective term and loudness is the subjective perceptual term. Loudness is predominantly controlled by subglottal pressure. And subglottal pressure, when you increase subglottal pressure, you increase the amplitude of vibration of the vocal folds. And the vocal folds snap back together with a greater force, thus creating a greater pressure disturbance, creating a louder sound, a more intense and a louder sound. You can see soft phonation with relatively small amplitude of vibration. Here's loud phonation, so a very large amplitude of vibration. So subglottal pressure is a primary control variable for intensity and loudness. When pressure is greater, fundamental frequency will also be slightly greater as well. So pressure is a primary control variable for loudness, but all things being equal, when you have a higher pressure, a higher subglottal pressure, the pitch will also be higher as well. So here you can see the relationship between frequency on the y-axis and mass on the x-axis. So when mass is increased, fundamental frequency goes down. And now we're looking at a series of lines for various subglottal pressures. So here we have 4 centimeters of water, 8 centimeters of water, 12, and 16. So you can see as pressure increases, fundamental frequency also increases. So you can increase pitch by decreasing mass and vibration or by increasing subglottal pressure. That being said, you can control pitch and loudness independently. This figure shows kind of the relationship between CT muscle activation and TA muscle activation and fundamental frequency. So each of these lines is a particular fundamental frequency. So here's 100 hertz, 110 hertz, 120 hertz, 130 hertz, 140 hertz, 150, 160, 170, and so on. And here we have percentages of activation of the CT muscle and percentages of activation of the TA muscle. So for example, here would be 100% activation of the TA, here would be 100% activation of the CT. If we're looking at kind of 50-50, so here's 50% activation of the TA, here's 50% activation of the CT, it would be something close-ish to about 160 hertz. But how can you get 160 hertz? Well, you can get it with a lot of different percentages, a lot of different ratios of CT to TA activation. So there's more than one way to skin a cat, so to say. You can get these different frequencies by activating the TA and the CT muscle with different amounts. But note this. So if we're looking kind of after you get past about 40 or so percent, what happens when you get higher than 40%? So 40, 50, 60, 80, 100% activation of the TA. A little bit more TA activation doesn't really result in much pitch change for the most part. It doesn't change too much after about 40%, 50%. What happens with CT contraction? A little bit of change in CT contraction changes the pitch drastically. A little bit of contraction here, and you're gonna, a little bit of change in the CT activation, you're gonna have a much different pitch for a majority of these frequencies in here. Kind of tell that the CT is the main pitch changing muscle by kind of dissecting these data. The takeaway here is when stiffness increases, fundamental frequency increases. So when CT activation, which would increase stiffness, when CT activation increases, your fundamental frequency is going to increase. Say the vocal folds are mass loaded due to edema. Well, then you might have a lower fundamental frequency. Maybe you had reflux because you went drinking the previous night. Well, your vocal folds might be mass loaded, and so your voice might sound a little bit lower. What if you increase the subglottal pressure? Well, that's going to increase the vocal fold amplitude of vibration, which is going to increase loudness and intensity. And it actually might increase stiffness slightly too, because as you apply a greater subglottal pressure, you're stretching the vocal folds slightly more, which is going to slightly increase fundamental frequency. So stiffness, mass, and subglottal pressure control what the pitch and what the intensity is. So a note about quality. So quality it has that kind of a perceptual connotation like hoarseness, roughness, whatever, but it also has the connotation of adduction. So are we talking about breathy, balanced, or flow, or pressed phonation quality? Kind of that phonatory adductory range idea that I was talking about. Well, each of these different qualities, this kind of the breathy quality, the normal quality, and the pressed quality, they each have their own characteristic glottal volume velocity wave shape, so glottal pulse wave shape, their own electroglottography signal shape, I'll talk about that later, and their own spectral slope pattern. So how the amplitude of harmonics drops off across as frequencies increase. So generally speaking, when you have a breathy voice, you've got a lot of flow just going through between the vocal folds all the time. So you've got this kind of a DC flow. So a lot of air is passing through there. So you've got a modulating airflow component, and you've got a DC kind of a steady component. So you're losing, for example, maybe 600 centimeters squared of a second all the time. So this is just, so this kind of constant airflow. And then you've got a modulating airflow on top of that. Well, and then, so with normal, you have a glottal pulse that rises and falls. It actually goes to 0. So there's actually a complete closure of the vocal folds, perhaps in normal phonation. There's not complete closure, not a complete flow shut off in breathy phonation. And then in pressed, because the vocal folds are so tight together, there are these little pulses, and there's a lot of time when there's just nothing going through, no flow at all going between the vocal folds, because the vocal folds are so tightly adducted. Well, if you look at the actual spectral slope, the spectral slope gets flatter as you get more pressed. So this is kind of a normal slope. It's more slopey when it's breathy. And then when you have a pressed sound, it's a little bit flatter. Okay, so now we're kind of looking at breathy. So you can see there's a posterior gap there, allowing airflow to happen kind of all the time. So you're losing a lot of airflow. So you're going to run out of gas. You're going to run out of volume, of air volume pretty quickly with a breathy sound. Then you've got normal, so you've got complete closure. And then with pressed, you've actually got complete closure, and you might have some supraglottic kind of squeezing that's happening also. So again, breathy voice is produced with the most airflow, followed by normal voice. Pressed voice is produced with the least amount of airflow. So this figure here shows muscle activity for the TA, the vocalis belly of the TA specifically, the interarytenoid, and then the posterior cricoarytenoid during a particular vocalization. This is a sup and a zup. And so the bold line here is a sup, and the dashed line here is a zup. So here is time along the x-axis, and here is muscle activation in microvolts of the PCA, interarytenoid, and vocalis belly of the TA. So there's not much difference in terms of contraction of the vocalis muscle. There's a little bit of a difference in terms of the interarytenoid, but look at this. There's a huge difference in terms of the posterior cricoarytenoid activation pattern. So for the sup, the posterior cricoarytenoid, which is responsible for abducting the vocal folds, is very active during the s portion. Why? Because s is unvoiced. And so therefore, the PCA is active to pull the cords apart, to open the airway during the production of the s. While it's, and however, the PCA is not very active during the zup because z is voiced. This just shows you how the muscle activation patterns and vocal fold adduction patterns differ for voiced and unvoiced consonants during speech. Okay, let's talk a little bit about initiation, onset. So there's 3 different flavors of onset. There's the hard or glottal onset. Then there's the simultaneous or the balanced onset. And then there's the breathy onset. Ha, ha, ha. So, glottal, balanced, breathy. And a glottal onset is associated with hyperfunction of the voice. One thing you might try to quell the behavior of habitual hard glottal onsets in a patient that has vocal fold, that has hyperfunction, for example. Voice can terminate in 4 ways. You can either decrease subglottal pressure to such a small pressure that phonation doesn't occur. You could increase downstream resistance so that phonation doesn't occur. So that would be like trying to sustain phonation on a B, right? On a B consonant. So you're just basically filling the oral cavity. Your cheeks are kind of stretching. The air doesn't have any place to go. The anterior resistance is so much that you can't actually have a pressure drop across the vocal folds in order to make them vibrate, right? There has to be a pressure drop across the vocal folds, or between the vocal folds, across the glottis, in order for phonation to occur. You could also decrease or increase the gross positioning of the vocal folds outside of the phonatory adductory range. So you could abduct too far, so no phonation, or you could no more phonation. So those are kind of the 4 ways of terminating voicing. A little note about vocal registers. So this is more common to discuss in singing. However, I'll just cover it a little bit. So modal is the most common. So that's kind of related to the statistical mode, right? So this is when you have, it's primarily TA dominant production. There's maybe a little bit of CT, but a lot of TA involvement. Most frequently used register, and it's kind of the normal register. So it's what I'm speaking in right now. There's also falsetto, which is more of a CT dominant production. And that kind of sounds like this. I'm a real boy. So it's kind of like that. So the vocal folds are long and stretched and very tense. And then there's glottal fry. That's when you're going to talk like this. So TA dominates. The vocal fold cover is very lax. The body is more tense, so the TA muscle is contracted, and then it's commonly used at the ends of phrases. It's very low frequency. There are some folks that do it kind of habitually. Kim Kardashian's famous for using this. And then there's a whisper register, which is not really a register, but that's just talking like this. So this is aphonic. So there's no phonation during whisper, and the airway is open, right? So it's a grossly abducted configuration, right? A little bit about sex differences here. So here we've got age on the x-axis and vocal fold length on the y. So this is kind of charting the developmental course of male and female development. So vocal fold length grossly increases kind of similarly in both sexes. And once we get to puberty, at some point, there's a bit of a divergence where the male vocal fold length increases more quickly than the female vocal fold length. So the end result is males have longer, more massive vocal folds on average than females. Males have larger larynges than females do, and they have longer vocal tracts than females do. So grossly speaking, they're just larger. There's a little bit of what's referred to as sexual dimorphism between males and females in the human species. All right, and age effects. So now we're looking at males in kind of the cyan and females in kind of the purple here. So fundamental frequency starts really high, and with puberty, it drastically drops. So males, I mean, we drop like an octave. Females drop too, though. They drop maybe about a sixth or so, if we're talking about musical terms. So there is a decrease in both female and male fundamental frequency with puberty. And it kind of stabilizes out around 20 years of age or so, maybe a little bit before. And then as males age, they actually slightly increase in pitch. As females age, they kind of stay flat, or even some data is not shown here. They might actually lower their pitch slightly. And so they might actually converge a little bit here with age. So that's kind of poetic. We start together. It seems like we're going to end together as well. So that's kind of poetic. And just a couple of normative values. Average speaking FO, men, grossly speaking, about 125 hertz. Women, about 225 hertz. Pitch range for males and females, about 34 semitones on average, kind of the mean. And the range can be anywhere between 28.5 to 42 semitones or half steps. So that's the distance between the notes on a keyboard as a semitone. So da, 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 that's a semitone. So kind of looking at the chromatic scale there. And this varies quite a bit across individuals. You might have someone that has, an octave and a half range, fairly limited. Then you might have somebody that's got a crazy wide range, like Mariah Carey can sing with a very, very wide range. So everybody's a little bit different here. And with training, of course, you can expand the range. All right, so talking about voice disorders, what's the big deal? Well, the patient is unable to produce and control a normal voice with typical pitch and pitch variability, typical loudness and loudness variability, typical duration, and typical quality. And so as a result, they have some functional deficits. And they might have trouble, making themselves understood. Others might form negative impressions about them. They might have a difficult time using their voice for long periods of time, something that's, very tough, say if you're, a teacher or a lawyer or a doctor, somebody that has to use their voice all day, an actor, a singer. difficulty making and keeping friends, perhaps, and difficulty completing work at your job or at school. So here's a little voice disorders checklist. You might look at some of these when you're thinking about, well, what problems does this person have? SLPs and ENTs, so ear, nose, and throat physicians. So diseases and disorders affecting communication and swallowing, as well as surgical and medical procedures, can have detrimental effects on voice production. So patients that have a suspected voice disorder cannot be treated without an otolaryngological exam, as there are life-threatening conditions such as laryngeal cancer, airway compromise, that can present initially just as acute hoarseness. So they have to go to an ENT. We can't just stand alone. We have to collaborate. SLPs contribute information during the diagnostic process, and we can kind of describe the function, how tissues look and move. But medical doctors, ENTs, also known as otolaryngologists, are the ones that give the actual medical diagnosis. So we do not diagnose patients. That's the doctors. As an SLP, you need to know what the larynx looks like. So looking for things like lesions, symmetry, mucosal wave, that sort of thing, how it's functioning, what the medical diagnosis is, what the medical or surgical treatment is, or management approach might be. So the goal of assessment as the SLP is to answer the question or questions proposed by the referring physician. So first you need to establish an etiology, like what is going on here? What's the problem? So they might have a particular diagnosis provided by the ENT, and you kind of have to figure out, well, what is the functional breakdown here? What are the factors that are contributing to the disorder? And kind of figure out which factors are the most significant. What's the severity of the disorder? What's the patient's prognosis? Like, do they have a good chance of of improving their vocal behaviors? What might be the best behavioral treatment approach? You might trial that a little bit. Identify outcome measures that will support treatment effectiveness. And then you might determine other appropriate referrals to other physicians, such as maybe a neurologist or a gastroenterologist, along with the ENT. ENTs oftentimes will collaborate with gastroenterologists and neurologists. So you need to look at the patient's disorder history, their surgical history. You might perform a subjective auditory perceptual analysis, like what does the voice sound like? You might perform some objective instrumental measurement, and you might use some descriptive severity scales as well. All right, talking a little bit about disorders. So voice disorder diagnosis and etiologies. So voice disorders can be organic or functional. Organic means that they're due to some abnormal tissue or structure. Functional means there is no abnormality of the tissue structure. And underneath the organic umbrella, organic disorders can be benign, meaning non-cancerous, or they can be malignant, meaning that they're cancerous. And squamous cell carcinomas are the most common. Benign organic disorders can be structural or neurological. Structural disorders include things like nodules, polyps, cysts, edema, Reinke's edema, contact ulcers, granulomas, papillomatosis, leukoplakia, dysplasia, amyloidosis, sulcus vocalis, a lot of these different things. And they can be initially caused by poor technique or misuse. They can be caused by abuse or overuse, poor vocal hygiene, smoking, GERD, gastroesophageal reflux disease, any of these things, or maybe a combination. Oftentimes things are caused by a multitude of factors. Benign organic disorders can also be neurological. So things like paresis, so partial paralysis, spasmodic dysphonia, tremor, myoclonus, apraxia. And the etiology can be upper motor neuron disease, such as amyotrophic lateral sclerosis, a CVA, cerebrovascular accident, like a stroke, MS, multiple sclerosis. It can be a lower motor neuron disease, so recurrent laryngeal or a superior laryngeal nerve damage. It can be a brainstem stroke, MS, ALS, neurofibromatosis, idiopathic. Idiopathic meaning we don't know. I'm going to say that idiopathic means that we're idiots and we don't know what's going on. It could be extrapyramidal disorders, so things like Huntington's, cerebellar disorders, neuromuscular junction disorders like myasthenia gravis, muscular dystrophy, a traumatic brain injury, all kinds of things. So as I mentioned, functional disorders are when you have abnormal function, but in absence of any kind of anatomical abnormality. So the larynx looks fine, just the behaviors are off. It's a behavioral problem. So these can be either hyperfunctional, so too much muscular tension, for example, like a muscle tension dysphonia, or hypofunction, so not enough appropriate muscle tension. They can also be psychogenic or psychosomatic, so things like conversion event, psychiatric illness. So the behavior is connected to a psychological condition. So it might require referral to a psychologist or a psychiatrist, for example. And then there's other causes. So things like trauma, intubation injury is common, sports injury, assault, local irritation due to things like drugs, antihistamines, inhaled irritants, allergies, upper respiratory tract infection, GERD, or so gastroesophageal reflux disease or laryngopharyngeal reflux, or systematic effects from various systematic diseases. Now, first, you're going to get a patient disorder history. And disorder history provides most of the facts necessary to diagnose the dysphonia and determine the etiology. Some physicians are able to actually read the history and predict with relatively high accuracy what the diagnosis will be, in fact. The patient history often determines the direction of the assessment. So you'll have the patient kind of describe the problem, what the onset is, if it's sudden versus gradual, kind of the character of the dysphonia, if it's a constant or is it variable, what are their voice use patterns like in terms of their needs, what do they do for work, what do they do for leisure, what kind of school voice use patterns do they have, what are their responsibilities, any other associated events and comorbid illnesses that happened at the time that the dysphonia began. What is the duration of the dysphonia? Is it kind of a lifelong thing? Has it been going on for 6 months? Was it kind of an isolated event? Medical and surgical history. What medications are they taking? This includes illicit drugs too. Hydration, caffeine intake, smoking and alcohol use, history of psychological intervention, work and social history. What's their personality style? How do they cope with stress and anxiety? Are they getting good sleep? What are their sleep patterns like? But yeah, don't underestimate the power of a good history. You can learn a lot and really kind of pinpoint what the problem might be from the history. So a subjective audio-perceptual analysis. This is when you kind of develop listening skills to ID and discriminate voice characteristics. There is an issue with intra and inter-judge variability. I mean, intra meaning like you and yourself later, enter you and someone else. So the variability between you and another person and you and yourself later. This is not necessarily a reliable thing, right? This limits the use of a kind of a scale for perceptually rating voices. Training does exist to increase inter-judge reliability via listening to anchoring tapes. And these are periodically reviewed to check to see if they are appropriate. One good resource is this one here that I provided. This is for the Cape V, and this is anchoring training for the Cape V. And so I recommend you check this out and kind of give yourself a little bit of training on Cape V anchoring. And this is important to note. This is a very important point. It is impossible to tell the size and extent of any lesion of the vocal folds by the sound of the voice. You have to view the larynx to determine the conditions of the tissue. So yes, auditory perceptual analysis is great, but it cannot tell you what the actual larynx looks like and how big, like, for example, a lesion might be. There's not necessarily a one-to-one correspondence. I've seen super healthy, normal-looking larynges that produce a terrible sound, a very, very dysphonic sound. And then I've seen larynges that look like they look pretty bad, and they're actually able to compensate for it enough that it sounds relatively normal. So the larynx has to be viewed. Tasks for auditory perceptual analysis. There are standardized elicited tasks such as sustained vowels, S to Z ratio. So the patient will hold S as long as they can, then hold Z for as long as they can. There are pitch glides. Ah, ah. Loudness modulations. Ah, ah. Oral reading passages such as, the Rainbow Passage, Morgan Williams, the Grandfather Passage. There's vowel initiation tasks that might be conducted. Unvoiced initial or voiceless contrasts, voice continuance, coughing, throat clearing. And then there's free conversation. So in the you'll observe the appropriateness of pitch, loudness, pitch and loudness ranges and variability, the duration, quality aspects, and see if there's anything that's off. So you're kind of taking notes regarding what aspects of the voice are abnormal. There are a few different vocal quality measures that are used. I've discussed these a little bit before, but there's the GRBUS, the GRBUS, or the grade roughness, breathiness, asthenia strain scale here. And so you can kind of rate these various aspects of the voice on a 4-point scale. There's the CAPE V, which is very commonly used. And this rates overall severity, roughness, breathiness, strain, pitch, and loudness. And like I mentioned, look at the CAPE V anchors. If you're going to use this, that can help increase your inter-rater reliability with other clinicians. Here's the CAPE V. So you have the patient sustain the vowels ah and e for 3 to 5 seconds. You have them produce these sentences. The blue spot is on the key again. How hard did he hit him? We were away a year ago, etc. And then spontaneous speech. Tell me about your voice problem, or tell me how your voice is functioning. And then you rate them along this scale. It's got kind of a mild, moderate, and severe kind of anchors along this Likert-like scale. And then once they rate, once you put a line there, you can convert it to a 0 to 100 score. You rate whether it's a consistent or an intermittent problem. You might also rate pitch and loudness, maybe other additional features such as fry, falsetto, aphonia, tremor, that if you choose to add those as well, you might have some comments about resonance, and that's the CAPE V. So regarding descriptive severity scales, voice disorder can be judged from the perspective of the patient, from their family, and or the SLP. And so it's good to get a severity rating from each person. So what the patient thinks of their dysphonia is highly important because they're the one that's using their voice, right? The patient's family matters because they're going to be the primary people that the patient is communicating with, most likely. And then the SLP is the one that's kind of the trained individual. So they kind of have the benefit of perspective, seeing how functional they might be relative to neurotypical or normal functioning individuals. There will oftentimes be a discrepancy between these 3 different groups, but all 3 of them are important. A patient's perceived handicap will be impacted by their lifestyle, by their personality, by social, avocational, and vocational needs. So patients with greater speaking demands will likely experience greater handicap given equivalent loss in function. And perceptions will often change throughout the continuum of care. So a patient might have been emergently intubated to save their life, and then over time a granuloma formed due to the presence of the intubation tube. And while it's early in the process, the granuloma was not really a big deal because we were just worried about saving their life, and they were worried about surviving. Well, once they get back, they start to recuperate. Well, the granuloma can become more of an issue because it's impacting their return back to normal voice use and normal life. So there are a number of patient-reported outcome measures, which are important to know a little bit about. So this is the gold standard for evaluating treatment effectiveness. So how did the patient feel like their voice improved over time as a result of the intervention? So the first one that was created was the VHI, the the Voice Handicap Index. And it's a 30-item scale, and it's got 3 subscales, kind of physical, emotional, and functional components. And a patient's score must change by 18 points in either direction to demonstrate a change that's not related to random variation. There's also a shorter version, the VHI 10, which is kind of a condensed version of the VHI that only has 10 questions on it. So here is the VHI, and here's the VHI 10. So here's the functional, the physical, and the emotional subcomponents. And there are functional, physical, and emotional questions in the VHI 10 as well. And so if you are kind of short on time, maybe the VHI 10 would be a good one to use. It has good, it has been validated against the original VHI. And so it's a good tool as well. And it's a little shorter. There's also the voice-related quality of life tool. And here's a voice disability index also. So a few other tools exist that you can use for self-ratings of voice. Sensitive, specific, valid, and reliable tools are necessary for assessing quality of life and the effects of medical, surgical, and behavioral intervention in order to satisfy third-party payer demands for demonstrated treatment effectiveness. So if we demonstrate a large magnitude of change, like so a large effect size of change that's not due to statistical error, like so it's got a low p-value, and we use good tools to do that, then we can justify to the payer, to the insurance companies, that we made an impact on this person's life, functionally, emotionally, physically. And information from the patient's history and auditory perceptual findings can facilitate hypotheses that we can then test during the objective instrumental evaluation. So objective instrumental measures, the clinical voice laboratory. I should mention that for 2 years, I was the voice lab technologist for Robert Sadloff in his clinic in Philadelphia, the PINTA, Philadelphia Ear, Nose, and Throat Associates. So after my first graduate degree, I got an undergrad and a master's in opera and voice performance. I decided that I wanted to go into something that was a little bit more sciencey, and I ended up being employed by him. And I took all the incoming clinical voice laboratory measurements, all the objective instrumental measurements for all of his incoming patients. So this is something that is near and dear to my heart, objective instrumental measures. So when talking about objective instrumental measures, we're referring to hardware and software for measuring acoustics, aerodynamics, and glottographics, as well as laryngeal imaging. During observation of laryngeal imaging, the ENT and the speech-language pathologist might collaborate during this procedure and then educate or instruct the patient, motivate the patient, justify treatment needs, and possibly provide feedback as well. You can do repeated pre and post-treatment measures to kind of track progress over time. And it gives the patient and the clinicians objective documentation of the pathology that's more convincing than just perceptual judgments. We can track objective changes to the acoustics, aerodynamics, and glottographics. And it also it justifies services to third-party payers better than, say, simply subjective measures. The protocols for collecting data used for evaluating voice function have been developed, and normative data have been collected to allow for comparison. And one resource is, that's a fantastic resource, is Clinical Measurement of Speech and Voice by Bacon and Orlikoff. So tasks here might include sustained vowel production, speech and voice production at comfortable habitual pitch, high and low pitch, pitch glides, glissando, soft and loud voice, passage recitation, and conversation. When making comparisons between measures, you have to determine that the measures have been calculated in the same way, or else comparisons will not be valid. Like, you can't just compare apples and oranges. So you have to be careful that confounding factors do not interfere with the validity of the measures. And one of those factors might be, well, was the calculation performed a different way? Instruments can be used for assessment. They can be used for treatment monitoring and direct biofeedback of voice production. They can be used for understanding the capabilities of normal and professional or trained speakers and singers, and the limits of voice production in patients with disorders as well. And you should note that all non-invasive instrumental measures, voice measures, are indirect estimates of various aspects of vocal function. And so they allow for inferences about particular aspects of vocal function, but they don't give the full picture. So you have to know what it is that you're actually looking at. You can't make broad inferences from very specific data. Here are a few instrumental measures in the voice laboratory. So there's acoustic recordings and analysis, aerodynamic measurements. So we're looking at pressures and flows, laryngeal videostroboscopy, so imaging the vocal folds, There's electroglotography, so looking at the vocal fold contact area, and then electromyography, so looking at muscle activation patterns. And there are a number of measurements that are yielded by each of these types of techniques, and they all require particular equipment in order to perform them. Acoustic analysis is the most frequently used as it's quick and it's easy to collect. It's pretty affordable as well. You need a microphone, maybe a preamp, computer, and software for analysis. And I provided you a couple of links for some good free software. So this is Prot. It's an excellent free software analysis. So this is Prot, and yes, the website does look like it's from the early 90s, but it's still really terrific software. So they have it for Mac and Windows and a few other things as well. And then Tolvan, this is a good website to check out. So they have some pretty neat stuff. I would point out especially RT-Sect, which is a real-time spectrum display. So this gives you kind of a real-time spectrum that you can use for feedback. And there's a lot of excellent software here as well that you can kind of explore. So as I mentioned previously, fundamental frequency is the rate of vibration of the vocal fold, so the number of cycles a second, or hertz. So you might look at the mean FO, the mean and the max, so the range. So FO is directly proportional to tension, so increased tension, you increase FO, and it's inversely proportional to mass and length. So if you increase the mass or the length, then FO is going to go down, right? With children and adults, children have smaller vocal folds, adults have more massive vocal folds. And sex, males have more massive vocal folds, females have less massive vocal folds. So there will be expected differences between sexes and across the age continuum. So one thing to note relative to objective measures is that you can't compare intensity levels recorded and or analyzed by one piece of equipment with levels recorded and analyzed by another. So you have to calibrate it with a sound level meter in order for the measurements to be comparable. You have to consider ambient noise, like the general kind of noise level in the room, the microphone type. Mouth to mic distance is very important. This has to be controlled due to the inverse square law. As you increase distance, you're going to affect intensity quite a bit. So also be wary of putting the mic too close as well, because that might end up result in peak clipping. So signal distortion, where the tops of the peaks of the audio waveform are kind of cut off. So peak clipping. Relative to acoustics, there are also perturbation measures, which are cycle to cycle variability in frequency. For example, in the case of jitter, rap, PPQ, and intensity in the case of shimmer and APQ. There's multiple ways to calculate perturbation. And so I've provided a little bit of information about perturbation in these articles here. So Pentax Medical produces the computerized speech lab as well as the VisiPitch, which can be used to assess perturbation via the multidimensional voice profile software program. And so this is something to kind of check out. So here we're kind of looking at amplitude modulation and frequency modulation. So there will be a slight difference from cycle to cycle in terms of amplitude in a normal voice. So it's not just going to be completely constant. And so when the amplitude is modulated, that might manifest as intensity modulation, which might be measured as shimmer via a very particular calculation. And there will also be slight changes in the period of vibration. So slight differences, cycle to cycle differences in the period, the frequency. And so that might manifest as a change in the jitter measurement. Jitter is calculated via a very particular equation. And so these equations are in these resources here. There's also harmonic to noise ratio, which is a calculation of the amount of relative periodicity to the amount of noise present in the acoustic signal. And it's important to note there's also signal to noise ratio and noise to harmonic ratio, which are similar measures, but they each have their own particular algorithms for calculation. And you can't compare one to another. You have to make sure that you're comparing like to like, right? As I mentioned, there is this kind of a Yanagihara classification of type 1, type 2, type 3, type 4 signals. So you're increasing the amount of noise as you go from type 1 to type 4. This is a bit of an older characterization of signals, but this does exist. There's the voice range profile, also known as the phonetogram, which is a very cool display of frequency and intensity. So along the x-axis, you have pitch range. And along the y-axis, you have intensity. So you're looking at basically the minimum and the maximum frequencies that the patient can produce, and the minimum and maximum intensities that he can produce on those pitches. So you're kind of creating this kind of a slug, an area pattern, kind of charting what intensities they can produce at a variety of different frequencies. And this is more often used by singing teachers than a speech-language pathologist, although we have speech-language pathologists can use these. And it's good to kind of chart changes over time relative to intensity and frequency. So we need to talk about the spectrogram here. So with the spectrogram, the x-axis is time. So we're looking at time here, and we're looking at frequency on the y-axis. So x-axis is time, y-axis is frequency, and the darkness indicates the intensity of the sound. So there are two basic types, the narrow band and the wide band. Narrow band is good for, it has fine frequency resolution, but poor time resolution. So it can view individual harmonics, but in terms of timing aspects like onset, for example, it's not very good at measuring timing. The wide band, on the other hand, has really fine time resolution, but poor frequency resolution. So it's good at measuring timing events like onset, maybe voice onset time, for example, but it has poor frequency resolution. So you can't see individual harmonics. But you can see, because it has such good time resolution, the individual glottal pulses. So you can see the space between dark vertical band and dark vertical band. That's the period that relates to one cycle of vocal vibration. You can also see grossly where the formants are, kind of the center frequency of the formants. Because the time resolution is kind of low, you can kind of see where the center of the formant frequencies are. And I should also note out, relative to analysis of narrowband frequencies, Tietze came up with this different characterization of signals, type 1, 2, and 3. Type 1 is periodic, low noise level signals. It's best for acoustic analysis. Type 2 signals don't always have a clear FO, so they have more noise. Type 3 signals are chaotic. There's no regularity to them. And they're inappropriate for analysis of FO. So type 1 signals are best for acoustic analysis. Sorry, there's also the spectrum. And the spectrum has frequency on the x-axis and intensity on the y-axis. So if you take a slice in time of a spectrogram, you can output that as a spectrum. So if you're to kind of take this little slice here, you got this formant here, and that formant here, you can kind of see that's here, here, and there. So you can kind of see that this spectrum is kind of a slice in time of the spectrogram. And the dark bands here, there, and there correspond to formants. And so you can see those formants corresponding to the peaks here, there, and there. So spectra are good for measuring formant center frequencies, bandwidths, and spectral slopes. You can also do an aerodynamic analysis. And these are measures that assess the degree and efficiency of vocal fold closure. We're basically looking at pressures, flows, and resistances. So air pressures, air flows, and airflow resistances. Aerodynamic measures require equipment calibration and complete face to mask seal. So no leaks. And this is essential to minimize measurement error. Leaks will screw up your measurements. And there are a number of common aerodynamic measurement systems, such as the Glottal Enterprises system and the Pentax system. I have used both of these extensively, and they are both good for the purposes for which they are intended. So calibration is the comparison of measurement values delivered by a device under testing with those of a standard with known accuracy. So, for example, in my dissertation, I had to calibrate our Glottal Enterprise's pneumotachographic mask system for airflow in order to make sure that the measurements were valid. So the device measures a pressure drop across this mask and relates that to some voltage output of this transducer here. Well, if the voltage output is not related to some kind of a real world value via some kind of an equation, a calibration equation, then those voltages are meaningless. So for example, you have to run a series of flows through the mask and then attach a meter of some sort that is already calibrated, maybe, or maybe it has an inherent strong calibration, like an airflow meter or rotometer, and measure the amount of milliliters a second going through the system that then corresponds to that particular voltage. And then you create an equation relating those two things. So when you have a given mask output voltage that relates to a certain amount of airflow. And so then you can create an equation that relates voltage to airflow. So you have to do this anytime you're using aerodynamic measuring equipment. You have to calibrate it first in order to make sure that it's accurate. So a note about aerodynamic measures. Aerodynamic measures, like I said, when we're talking about aerodynamics, we're talking about airflows and pressures and resistances. Well, there's this law, the aerodynamic version of Ohm's law. So it relates airflow, pressure, and resistance. So it states that mean airflow is equal to pressure drop across a resistance over the airflow resistance. So when you have a higher pressure drop, that means the airflow is going to go up. When you have a higher resistance, that means the airflow is going to go down. So when this goes up, this goes up. When this goes up, this goes down. So one of the main aerodynamic measurements is average glottal airflow through the glottis during phonation. So this is measured in milliliters a second or centimeters cubed a second. And this is the same. 1 ml a second is the same as 1 centimeter cubed a second. Higher airflow volume is expected given more subglottal pressure and or less glottal airflow resistance, right? So when this is higher, this is higher. When this is higher, this is lower. Glottal volume flow or glottal volume velocity, these are kind of interchangeable terms. This is the instantaneous pulsatile flow through the glottis during phonation. And it's represented as a time varying waveform. So we're looking at as the vocal folds separate, airflow increases. Eventually, vocal folds separate maximally, and there is a maximal airflow through that gap, and eventually the vocal folds come together and the airflow shuts off. So we've got a complete cycle of airflow that kind of corresponds roughly to a cycle of vocal fold vibration. So as the gap gets bigger, more airflow goes through. As the gap gets smaller, less airflow is through. The source of sound in phonation is the changing glottal airflow. So this is what actually creates the sound. It's this airflow. And when you change the shape of the airflow, you actually also change the acoustics. That's why it's important to look at aerodynamics, or one of the reasons anyway. So when you increase the maximum flow declination rate, so the point where flow declines the most, so right here. So if you're looking kind of at the instantaneous rate of change, you can see there's a point around here where airflow is shutting off the quickest. Well, that's the maximum flow declination rate. When you increase that by double, you increase the overall sound pressure level by 5 to 9 dB. When you increase the flow pulse amplitude by double, you're increasing the spectral level of the FO by 3 to 7 dB. When you make this flow shutoff corner change from a more rounded shape to a more kind of a sharp shape, you can increase the dB of higher harmonics by 10 to 20. Maybe an increase in 10 to 20 dB of those higher harmonics. So the shape of the glottal flow signal is very important, especially with respect to acoustics. So subglottal pressure is the air pressure created by the respiratory system below the larynx with dependence on degree of glottal adduction. So static subglottal pressure is expected to increase with increased airflow resistance. That is more vocal fold adduction, given the same respiratory system recoil force and torso muscle contraction force. This is directly measured via a transcutaneous needle into the trachea below the vocal folds. However, this is very invasive. So we don't do this very often. Instead, we can indirectly measure subglottal pressure via intraoral pressure, via a very particular task. So a tube is placed between the closed lips during production of a repeated syllable sequence. So the voiceless plosive p plus a vowel, usually a, or e. So pa, 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 or pa, 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 or p, 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 p. Because the intraoral pressure is equal to subglottal pressure during the p phoneme, so p, p, one assumes that subglottal pressure is the same during the phonation as during the p phoneme. That being said, you have to take care to produce the syllable string smoothly, to maintain constant respiratory pressure during the task, use appropriate consistent syllable rate, make a complete seal with the lips around the tube, and check the tube for saliva occlusions. So you have to be very careful about this, but you can measure subglottal pressure indirectly using this task. And my colleague Brittany Perrine did an excellent article that provides some recommendations regarding signal interpretation. So transglottal pressure is subglottal pressure minus supraglottal pressure. It's basically the pressure drop across the glottis. And it's also referred to as the driving pressure sometimes. And note that if the supraglottal pressure is approximately 0, then transglottal pressure will be approximately equal to subglottal pressure, right? And I mentioned the 4 methods of ceasing phonation, so that's a little bit redundant there. But note that lesions, scarring, paresis, all these various disorders can cause the vocal folds to vibrate asynchronously. And that requires more pressure in order for phonation to occur. Transglottal pressure must be sufficient in order for phonation to happen. And there's a minimum pressure that's required for phonation to be initiated and sustained, and that's referred to as phonation threshold pressure. So here we go, phonation threshold pressure. The minimum lung pressure required to initiate, that's the onset, and sustain, that would be the offset, phonation. So PTP, there's PTP at onset and an offset. And so this is a little figure from my dissertation here where I measured a number of aerodynamic variables, but you've got PTP at onset and you've got PTP at offset. Typically, it requires more pressure to onset phonation than to offset phonation. So typically about 3 to 5 centimeters of water at onset, 1 to 2 centimeters of water at phonation offset. So mathematical and computer modeling studies suggest that PTP increases with supraglottal resistance, vocal fold abduction, glottal convergence versus divergence, mucosal wave velocity, and vocal fold tissue viscosity. Studies by Tietze indicate that PTP decrease with supraglottal vocal tract inertance and vocal fold thickness. And then clinical research suggests that PTP also changes with external hydration and drying, with vocal fatigue and systematic internal hydration, and with phonatory effort and vocal loading. If you're breathing in dry air, you're internally dehydrated, you haven't been drinking a lot of water, you're fatigued, then it's going to require more pressure and effort to phonate. Glottal airflow resistance is the resistance to airflow offered by the vocal folds. And it's primarily a function of adduction level. So more adduction, more airflow resistance, glottal area, smaller area, more resistance, and glottal geometry. Divergent geometry here yields less flow resistance, and the convergent glottal geometry here yields more flow resistance for the same diameter or gap. All right, now a note about electroglottography. So this estimates contact area between the vocal folds. A high frequency, low amp signal is sent through the tissues of the neck. When the airway is closed, meaning the vocal folds are in contact, the tissue acts as a better electrical conductor than the airspace. So thus the electrical impedance between the electrodes is reduced. So therefore the signal increases in height. So there's more electrical current through the neck tissues when the vocal folds are in contact than when they are not in contact. So the greater the vocal fold contact, the greater the electrical current, and the higher the signal amplitude. You can also see kind of a gross shifting, kind of a DC shift, kind of a block shifting of the whole signal up and down, given an increase or decrease in a laryngeal position. And so you might see this when the person swallows, for example. So vocal fold contact area and the EGG wave morphology changes with adduction and with register. Okay, so going back to this figure, we see breathy, normal, and pressed. Here's our glottal volume velocity signal. So we see there's a high amount of DC all the time, airflow. There's a modulating flow. It looks almost sinusoidal. Normal, it shuts off all the way to zero. So there's complete closure. Pressed, there's a lot of closure and not a whole lot of airflow going through. EGG, we have for the breathy sound, we've got a little bit more narrow contact area. So here we have the vocal folds in contact. So electrical current is going through quickly, abruptly, because there's quick contact. And then eventually there's less and less contact as the vocal folds kind of peel off each other. And you can see that this is a narrower signal, wider signal still. So the percentage of time that the vocal folds are in contact is greatest with pressed, moderate with normal, and least with breathy. Electromyography, EMG, measures nerve and muscle function. And you can do this either with surface electrodes or insertion of needle electrodes into specific muscles. And you can measure the muscle activity during phonation and breathing. This is commonly performed by, the insertion procedure is commonly performed by a neurologist or an otolaryngologist. And this is typically conducted to test for paresis or paralysis, or to guide injection of Botox injection for spasmodic dysphonia patients. And I've seen this procedure done. It's quite interesting. And you can differentiate patients with paresis or paralysis from a retinoid fixation or a retinoid dislocation, for example. So is it a problem of the nerves or is it a problem with a joint? Photoglotography, PGG, is another method. I used this during my dissertation. You pass a light through one side of the vocal folds, and then you collect it on the other. So the light can be above or below. There just has to be a collecting photodiode on the other end. And then the voltage that is output from the photodiode is roughly proportional to the glottal area, because the light coming between the vocal folds is changing with the glottal area, and thus the glottal area is changing, and thus the light coming through is changing, and thus the voltage output from the photo collecting diode is changing. So the voltage is roughly proportional to the glottal area waveform. So this is an example of an objective voice assessment that I conducted while I was working in Philly. So we have a particular patient here. All the identifying information has been removed, but this individual had a diagnosis of dysphonia, just kind of that broad term of a voice problem. They had bilateral vocal fold paresis, left decreased abduction and adduction, right decreased abduction. They had reflex laryngitis, rhynchus edema, and narrow glottic opening. And so when they performed a conversational sample and a reading sample, Marvin Williams's passage, the mean frequency was severely below norm for both. So the fundamental frequency of vibration was severely low in this individual. The physiological glide and a scalar glide was conducted to assess frequency range, and her range was severely below norm. Perturbation measures were conducted, so kind of the cycle-to-cycle variability, and also some noise to harmonic ratio. There were some deviations from norm for these perturbation and noise to harmonic measurements. The spectral type, Yanagihara, was type 2, so there was quite a bit of noise present in the spectrogram. Maximum phonation time was mildly below normal. S to Z ratio was actually within normal limits. Mean flow rate aerodynamic measurement was actually within normal rates, within normal limits. VHI 10 was abnormal. Her perceptions of her voice were that she had some problems. And here's a summary of the report. Here's a report summary at the bottom. This was her conversational and Marvin Williams reading passages. Note that there was a break, a voice break there during the pitch glide. So some aphonia. If we're looking at the output from the multidimensional voice profile from the CSL, the computerized speech lab, Most of the perturbation measures here were normal except for soft phonation index and VFO. And she had some abnormal respirometric measurements as well. You will oftentimes do respirometry to kind of test the lung function. And her FEV1, her forced expiratory volume in 1 second, was only 19% of predicted. And her forced expiratory flow between the 25th and the 75th percent was only 8% of predicted. So she had some significant respiratory impairments. And so this would be a person that you say, okay, there are some significant voice issues, but there are some very significant respiratory problems as well. And so you let them know, you let the ENT know. Laryngovideostroboscopy has been used by ENTs to diagnose voice disorders, and it's also been used by SLPs for decades to examine laryngeal function. So typically you have all of this equipment here in order to perform the exam. And you can either use a rigid or a flexible endoscopic exam. Rigid endoscopy, like you see here with this rigid endoscope, is better at visualizing tissue abnormalities. It's got just a finer, a better resolution. So you can see lesions and scarring better. It's not indicated in patients with a hyperactive gag reflux, TMJ disorder, or trismus. So with those patients, you might try flexible instead. But it is very useful for imaging lesions. Unfortunately, you can't do anything other than while you're doing that, because the SLP or the ENT is holding the patient's tongue with kind of a gauze pad and then inserting the rigid endoscope in through the oral cavity. Flexible endoscopy, however, is done transnasally through the nasal cavity with a flexible endoscope. So you can visualize naturalistic speech. It's similar. It's basically the same as the FEES. You've got the transnasal endoscope looking at the larynx from above. And with flexible endoscopy, you can look at gross motion abnormalities, so paralysis, paresis, retinoid dislocation or fixation, signs and symptoms of spasmodic dysphonia or tremor, paradoxical vocal fold movement, other neurological diseases. And it's good for examining naturalistic speech and singing as well. During the laryngovideostroboscopic evaluation, you're going to look at vocal fold appearance, vibratory characteristics, lesion characteristics and location, vertical and medial to lateral levels of approximation of the vocal folds, supraglottic activity, all sorts of things. You might look at glottal closure pattern, presence of mucosal wave, so kind of the phase difference between the inferior and superior margins of the vocal folds, vibratory amplitude, periodicity, symmetry, and the relative open and closed phase of vibration. And there's a stroboscopic examination form that was created by Poburka that has got a decent guidance for rating some parameters. Now I will show you a stroboscopic video of a patient. Hello, my name is Nicholas May, and today is August 27th, 2012.
Is it kitty cat?
Kitty cat.
Breathe through your nose. Reaching up. Okay, say your name.
My name is Nicholas May.
The date today is?
Today is August 27th, 2012.
Okay. Take a deep breath and say E for 20 seconds.
E.
Good. And go E, E.
E. E.
Glide.
E.
Glide up.
E.
Okay, count to 10.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
And count to 10 in a whisper.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Okay, good. Now repeat after me. The puppy bit the tape.
The puppy bit the tape? The puppy bit the tape.
We mow our lawn all year.
We mow our lawn all year.
Hum happy birthday.
Hum?
Oh.
Oh.
Can you go eat?
E. E. E.
Slow?
E.
Slow. You slow the camera. There you go. Now do that 10 times.
E. 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 E.
Okay, now say padaka, padaka, padaka.
Paraka, 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 paraka.
Now go back to E.
E, 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 E,
Okay, good. Now stick out your tongue. Good. Now put your tongue back in and puff out your cheeks. Good. Now unpuff your cheeks. Just breathe for a second. It's gonna be a closer look. Now can you switch to stroboscopically, please? Okay. Take a deep breath and say E for 20 seconds. Straight 10 at the bottom. Okay, good. Clear your throat a little bit there. Okay. Can you give me a higher pitch? That same note again. And can you change the note this time? What would you like? First is slow. Slow, and then the effort velocity. Okay, go.
Do you want louder or softer or what?
Oh, I just want the pitch. High. We're almost done.
Okay.
Okay, good. One more time. This is last, I promise. All right, we're all done. You did great. I'll show you what we're looking at.
All right.
So I'll talk a little bit about the principle of stroboscopy. So a series of snapshots of the vibrating vocal folds is taken at increasingly later times in the glottal cycle. And these snapshots are then linked together and played back as a video on the monitor. So the stroboscopy provides the illusion of continuous vocal fold vibration, but in actuality, you're only seeing a series of snapshots at a particular moment in time, and you're missing most of the information. So if here is the true vocal fold vibration, you might be seeing this snapshot here, this snapshot there, and there. And then it's reconstructed and played back to give the illusion of continuous vocal fold vibration. Here's a stroboscopic video of the silicone larynx that I made as part of my dissertation. So the use of stroboscopy to observe vocal fold vibration requires the assumption that successive cycles are reasonably similar to each other, since most of the information is missing. So in order to use stroboscopy, vocal fold vibration must be regular or periodic. How then would you observe irregular or aperiodic or chaotic vocal fold vibration? Well, you have to use high-speed video. So on the plus side, no information is missing, but on the minus side, it's not commercially available anymore. Systems have to be custom built. They're very expensive. They only record a short period of time, like maybe 4 seconds, and requires massive amounts of data storage space. When Dr. Sadloff had one back when Pentax was still making them. I think 4 seconds took up about 15 gigs of memory, and then we could compress it down to like 4, and you could splice the little particular moments that you wanted, and then condense it down to maybe 4 gigs, but still it was a massive amount of information. So here's an example of that, of a high-speed video. That's a pitch break. Laryngeal video chomography is another technology that tracks the left and right vocal fold edges within this thin horizontal line here, and outputs the position of the right and left vocal fold edges in this gray image to the right. So in this gray image, the vertical dimension is time, and the horizontal dimension is the position of the right and left vocal fold edges. So you can see right-left vocal fold asymmetry of vibration quite well. So other assessment components, you might do an oral peripheral exam. So observe the oral structures at rest, during speech, during non-speech movements, evaluate laryngeal muscle tension, you might do a palpation of the suprahyoid, thyroid, and infrahyoid structures. You might make judgments about resting muscle tension and the extent of movement on contraction, evaluate base of tongue and jaw tension, observe body posture during sitting, standing, and walking, which might, postural factors can contribute to a voice disorder due to excess tension and poor posture. You might do an informal assessment of other aspects. So speech, language, hearing, cognition, and swallowing is needed. So let's talk a little bit about voice disorders, about specific voice disorders now. Well, as I mentioned previously, functional disorders have normal tissue and structure. Organic voice disorders have abnormal tissue structure. But inappropriate production, that is overuse, misuse, and abuse, can cause structural problems. So nodules, polyps, cysts, contact ulcers, etc. So just because you're using the voice wrong, just because the patient is using the voice incorrectly, that doesn't mean that it just necessarily has to be a functional disorder. That functional disorder can then cause a structural or an organic problem as well. These are some definitions here. So abuse, sometimes it's referred to as large tissue forces, but abuse, some folks don't like that term. I have no problem with it because that's what you're doing. You're abusing your voice. So this is high tissue stresses, high impact forces. And when you abuse your voice, you're using it loudly, at high pitches, shouting, yelling, coughing, throat clearing, at high lung pressure and adduction levels. And it results in tissue damage of the vocal folds and at vocal processes. Overuse is repeated use of larynx to phonate. So overuse is phonating for long periods of time, and it can result in fatigue and tissue damage. And then there's misuse, which is basically poor vocal technique. So it's inefficient use of the larynx. So this might be high antagonistic muscle contraction levels that yield fatigue, laryngeal configurations that set the body up for tissue damage, like things are too adducted or too breathy, poor coordination that limits vocal fold or limits pitch range, restricts registers, creates too loud or soft voice, and it results in fatigue, tissue damage, and atypical vocal qualities. So functional voice disorders can be hyperfunctional, too much effort, or hypofunctional, too little effort. Hyperfunctional is more common than hypo, and oftentimes it presents as too much adduction or medial compression, and it can be associated with oppressed voice quality. Hypofunction, as I said, is relatively uncommon, and it might turn out to be something else like Parkinson's disease, ALS, or paresis. Muscle tension dysphonia is disturbed vocal fold behavior caused by increased tension of the paralaryngeal musculature. So imbalance of extrinsic and or intrinsic muscles used to produce voice And you often have supraglottic hyperfunction. So you have this kind of a squeezing of the supraglottal structures. So you might not even be able to see the vocal folds anymore. And it actually can be this supraglottic hyperfunction can be combined with glottic hypofunction. So you might have an underclosure of the vocal folds, but a hyperclosure of the supraglottal structures. The larynx might be immobile in the neck. The patient might indicate that there's pain in the larynx when upon palpation. They might have a globus sensation or a feeling of a lump in the throat at rest or during swallowing. MTD can be primary or caused by psychological stressors or secondary due to some organic disease. And management involves alleviation of tension. This might involve digital manipulation, massage, myofascial release, relaxation exercises, easy onsets, flow phonation, and possibly a referral to a physical therapist that the patient could work with synchronously or concurrently. Psychogenic disorders are psychological voice disorders. So these include conversion aphonia and dysphonia, mutational falsetto. And it starts out with the medical eval to rule out an organic cause. And then with the SLP's diagnostic voice eval, you collect history, see how the patient functions socially within their environment. You might prepare them kind of psychologically for change. You might explain voice physiology. You would not want to confront the patient with the possibility that the voice disorder is not physiological, because then that assures them that the disorder is real. And so you're de-emphasizing the psychological aspect. And you can try to do different manipulations of the voice. Boone has an excellent textbook that kind of discusses some of this stuff. But things like using nasally loaded hypernasal voice to kind of focus resonance anteriorly in the bony structures of the face to reduce tension in the larynx. Adduction modulation, flow phonation, so getting kind of a breathier, flowier kind of a sound. Facilitating voice for aphonic individuals via vegetative sounds, like if the person can't phonate at all, or there's aphonia, you might have them cough. If they can cough, try to have them sustain the cough into phonation. So like they're actually you're shaping phonation from a cough. You can do inhalatory or ingressive phonation. So phonating during inhalation can work. A negative practice where you're going to one extreme and then the other to kind of find the switch for controlling a voice parameter for the patient. You can work through a hierarchy of syllables, words, phrases, sentences, readings, conversational speech. So getting longer and more complex. Many patients with psychogenic voice disorders can return to normal or near normal voice relatively quickly. So maybe 1 or 2 sessions even, with occasional check-in or booster therapy sessions for encouragement, support, and maintenance after the fact. If there is persistent inability to return to voice despite demonstrated improvement, you might refer to a psychologist. So structural voice disorders, these are disorders these have aberrant structure associated with them, possibly due to phonotrauma. They can be chronic or they can be acute. So nodules are small, usually bilateral calluses that form on the vocal folds, typically in the mid-membranous region. So about 1/3 back from the anterior commissure, that's where they typically will form, this is the region of greatest amplitude, excursion, and the greatest acceleration, the greatest impact forces. So it makes sense that these kind of calluses would form in that region. They're the most common structural lesion. They can be acute, in which case they're soft and more pliable, or they can be chronic or hard, stiffer. And the patient outcome for elimination of nodules with therapy alone is excellent for acute, but it's kind of less certain for chronic nodules. Typically, the patient will start with therapy and see if that can ameliorate or eliminate the problem. And if intensive voice therapy has not done anything after about 3 to 4 months, then surgery might be considered. But therapy always has to be tried first before surgery, if nothing else, to eliminate the negative behaviors that cause the nodules in the first place. If you don't eliminate the root cause, which is the behaviors, they're just going to get the nodules back 6 months to a year after the surgery. So it doesn't make sense to not address that behavior. So polyps, are fluid-filled tissue lesions, kind of a sac, underneath the superficial vocal fold tissue. They're typically unilateral. They can be bilateral, but they're typically unilateral. And so you can have a polyp on one side and then a reactive lesion, kind of like a callus or almost similar to a nodule on the opposing side. And nodules vary in size, hardness, and shape. They can be sessile with a broad base versus pedunculated with a very narrow base that kind of gets wider as you get further out. So this is pedunculated here. If they're quite large, they might require immediate surgery if there's an airway obstruction risk, but this is pretty rare. They can also be supra or infraglottic, so above or below the glottis. They're often treated surgically with pre and or post-operative therapy. So you're going to want to eliminate the behavioral patterns that caused it in the first place, like I said, or else you're just going to get recurrence of the issue. And vocal hygiene education, for example, cessation of smoking might be necessary to ensure a good outcome. Here's Reinke's edema. So this is chronic hypertrophy of the cells, swelling or edema of the superficial layer of the lamina propria. So you can clearly see there's a lot of mass loading, a lot of swelling of the vocal folds. So the fundamental frequency will be very low. There'll be increased effort to get the vocal folds to vibrate. It's very common in smokers, so chronic irritation. It can also be related to chronic cough and laryngopharyngeal reflux as well. So kind of differential diagnosis between nodules and polyps here. Typically, nodules have a more gradual onset. Polyps, they can be gradual, but typically it's more of a rapid onset with polyps. Symmetry, nodules are typically bilateral. Polyps are usually unilateral. Nodules are not hemorrhagic, meaning there's not a blood vessel that feeds them. Polyps can be hemorrhagic, so you can actually see a blood vessel feeding them. Like in the case of this one here, you can see that there is a clear blood vessel feeding the polyp right there. And they're typically, nodules are more symmetric, polyps are less symmetric, since nodules are bilateral and polyps are typically unilateral. So there's also cysts, which this is a membranous sac or cavity of abnormal character containing fluid. It's usually unilateral, like polyps, and therefore a reactive lesion can occur on the opposing side, just like with polyps. They can be long-standing. They can even be asymptomatic. And there might not be an apparent cause for the cyst, rather. They're often treated surgically with pre and or post-operative therapy, just like polyps. And cysts are typically one of two types, either mucus retention cysts, which are created by obstruction of mucus or salivary glands. And they can be due to inflammatory or traumatic processes, or there can be epidermal cysts. So these are often caused by trauma, inflammatory or developmental causes. And these cysts are lined with epithelial tissue, maybe filled with keratin and cholesterol debris. And these are referred to as true cysts. And so they're in the submucosa versus the superficial layer. Here's kind of a schematic of the structural differences between nodules, polyps, Reinke's edema, and cysts. So nodule, polyp, Reinke's edema, cyst. Another disorder is sulcus vocalis. So a furrow sulcus, or kind of a longitudinal scar along the rim of the glottis there and there. That's adherent to the underlying vocal ligament. So it's kind of a little bit of a groove or a scar. It can be asymptomatic. You might not always see symptoms in a person with sulcus vocalis. And there are multiple types. So there's physiologic sulcus, type 2, Bergature, and type 3. And there's different theories regarding the etiology of each type. Like, for example, type 3 might be caused by rupture of a cyst. And they, like I said, they might be asymptomatic. So no surgery might be needed. Maybe if there is if there are behavioral patterns that need to be addressed, you to just address those. If surgery is necessary, then type 2 might be treated with microdissection. Type 3 might be treated with excision. Vocal fold hemorrhage, so a ruptured blood vessel in the vocal folds. This will change the distribution of mass in the vocal fold tissue and disrupt the vibration. And if improperly managed, it can lead to scarring. So after a hemorrhage, after acute hemorrhage, acute rest is needed. So absolute voice rest for 2 days to even possibly a week, followed by a period of relative voice rest, so minimal voice use, light breathy phonation. And so the return to voice after that absolute period of voice rest is guided by an SLP. So the SLP kind of helps the patient reestablish voicing, proper behaviors, light breathy phonation, minimal voice use. And the timing of the return to voice use will depend on the particulars of the etiology, the size, the location, in collaboration with the ENT. The ENT is going to be the primary person that takes the lead on when the person should return back to voice use, but a experienced SLP will have a good idea as well. SLPs can train the patient in use of nonverbal communication strategies, and then, as I said, guide the patient's return to normal voice use during this relative period and beyond. So papilloma. These are aggressive, recurrent, benign neoplasms of the epithelium caused by human papillomavirus. Neglected or aggressive disease can lead to airway obstruction, even making surgery, essential, a life-saving procedure. So papilloma can either be congenital or acquired. Potentially, it can be acquired by the neonate in utero, possibly. Treatment is excision or microsection with cold instruments or ablation with a laser to restore normal airway contour, and possibly this in combination with antiviral meds like remdesivir is one. However, no current curative therapy exists. The recurrence is very unpredictable. So the prognosis is unpredictable. So it might recur within a month after the surgery or disappear forever after one treatment. Contact ulcers and granulomas. So ulcers are raw sores, pale or red in color, possibly located in medial or posterior arytenoid mucosa. So granulomas it's kind of an indefinite term applied to nodular inflammatory lesions. They're usually present on the arytenoid cartilages, in the posterior commissure and at the vocal process of the arytenoids. And you see it there and there. They're associated with aggressive speaking styles that cause increased pressure, so hyperreduction, irritation at the vocal fold processes. They're associated with reflux. They can be intubation related, resulting from the chronic irritation due to the presence of the intubation tube. And the longer the intubation, the worse the granuloma will be. They can reoccur if the inciting etiology is not addressed. For example, if they're caused by hyperreduction and the hyperreduction is not addressed, they might reoccur. And they're often treated with reflux meds, possibly surgery, steroids, maybe even Botox injection to reduce arytenoid contact force, and pre and or post-operative therapy. So arytenoid dislocations and vocal fold tears. Emergent life-saving intubation can result in dislocation of the arytenoids from the cricoid cartilage and or a tear in the vocal fold tissue. And differential diagnosis to discriminate arytenoid dislocation from paresis and paralysis is necessitated here. So the patient might undergo electromyography of the laryngeal nerves to determine if they are still functioning. If they are, then you suspect, it's probably arytenoid dislocation. And surgical intervention is required to address these issues. Laryngeal trauma is another thing that can occur. So ABCs of trauma evaluation, you have to establish airway, breathing, and circulation. Transoral intubation may be impossible or dangerous, as it could convert a partial obstruction to a complete one. So in some cases with laryngeal trauma, tracheostomy might be needed to bypass the obstructed segment in the airway. After stabilization, the patient might be assessed to determine the extent of the damage to the larynx via endoscopy, maybe CT scans. Reconstructive surgery would be required in many of these cases to restore the original airway anatomy, and might require multiple surgical procedures. And voice results are pretty difficult to predict. They depend on the locus and the severity of the damage. And normal voice might not return. It might just be return of functional voice. That might be the realistic goal there. There was actually a very sad case while I was at Dr. Sadloff's office of a 13-year-old boy that was shot in the larynx. It was collateral damage from a gang shooting in, I believe it was in Pittsburgh, I think, and he came to Philadelphia for treatment. And Dr. Sadloff reconstructed his larynx, and he actually got a decent result, a decent functional voice, but it wasn't. It was not something where he was going to be a famous singer afterwards, but he had a functional voice, which was an excellent result. Tracheotomy and tracheostomy. So tracheotomy refers to surgical opening of the trachea to achieve an airway directly from the anterior neck to the trachea, bypassing oral and nasal cavities, pharynx and larynx. So this is performed to bypass obstruction of the airway that might be occurring above the proximal trachea. Could be due to tumors, neck abscesses, bilateral paralysis, stenosis, swelling after trauma. Tracheotomy might be performed to provide stable, long-term, easy access to the airway. For example, if the patient needs mechanical ventilation due to chronic lung disease or systematic illness. The tracheotomy tube is more comfortable, better tolerated, and easier to care for than an endotracheal tube, which passes through the oral or nasal cavities en route to the larynx. So tracheotomy tube is more of a long-term comfortable strategy. Tracheostomy, this term implies kind of a permanent opening, although the two terms are commonly used interchangeably. Patients with the trach tube can phonate via manual occlusion of the tube or via a one-way valve placed on the end of the tube, such as a Passy-Muir valve, that allows inspiration through the tube but blocks expiration, such that exhaled air must pass through the oral and or nasal cavity. In order for this to work, though, if there is a tube cuff, the cuff has to be deflated prior to voicing, or the air can't pass around the tube to go out the mouth, or the tube has to be fenestrated so that the exhaled air has an exit path. Okay, acid reflux. So reflux is a likely cause of unexplained cough, globus sensation, so kind of a lump in the throat sensation, hoarseness, or chronic habitual throat clearing. It can be confused with sinus disease at times due to the thick mucus that's produced in reaction to the acid exposure. Mucus has kind of a protective function, so it's trying to protect the mucosa. And so it might actually be reflux, not postnasal drip, for example. So if the allergies have been managed by an allergist, you're taking whatever pills or whatever medications they recommend, and then you're still having these problems, maybe it could be reflux. Reflux can contribute to formation of ulcers and granulomas. So the ENT must control reflux before surgery to establish a clean surgical field. I mean, think about if you have a cut on your hand and it's trying to heal and you chronically pour a drop of acid on it every hour, do you think it's going to heal properly? Of course not. So you have to eliminate reflux. The patient has to continue reflux management after the surgery because obviously it won't heal properly. The ENT might refer out to a gastroenterologist for assessment. So for example, something like a 24-hour pH impedance study. That is kind of the gold standard to assess reflux, laryngopharyngeal reflux. However, it is relatively expensive, time-consuming, and cumbersome for the patient to have this probe down their nose for 24 hours. It's kind of uncomfortable. So the ENT might decide to trial reflux meds instead. So like proton pump inhibitors or H2 blockers might be trialed instead of the formal 24-hour pH impedance test. So there's two types here. So GERD, gastroesophageal reflux disease, acid and pepsin from the stomach flow up or reflux into the esophagus. The lower esophageal sphincter doesn't keep fluids in the stomach. So this is generally due to a weak lower esophageal sphincter. And it might be caused by indigestion of certain foods, high pressure in the stomach, etc. And so typical signs and symptoms might be acid indigestion or dyspepsia, feeling of overfullness, bloating, excessive burping, possibly heartburn. Laryngopharyngeal reflux is when acid and pepsin spill out of the esophagus onto the larynx and pharynx. So the upper esophageal sphincter doesn't keep fluids in the esophagus. So this is associated with non-specific symptoms such as mild hoarseness, which is worse in the morning, a foreign body or a globus, kind of a lump in the throat type sensation, nocturnal cough, chronic throat clearing. About 50% of patients do not get the classic signs and symptoms of GERD with LPR. And laryngoscopy often reveals thick mucus, redness, the arytenoids, posterior commissure, cobblestoning. And with severe reflux, it might get, ulcers, granulomas, leukoplakia, diffuse edema. And not interestingly enough, nodules often will respond to reflux medication along with voice therapy. So oftentimes patients with chronic nodules might actually have comorbid reflux. Most reflux is the result of lifestyle and diet. So high fat foods, alcohol, caffeine, large meals, eating late just before bedtime, these all prompt acid and pepsin to proliferate in the stomach. And when you're laying on your back, the sphincters don't valve as well, as efficiently. And so it can lead to refluxing into the esophagus and into the pharynx. So behavioral modifications include you don't eat 2 to 3 hours before bed. Elevate your head of bed. So don't just put a big pillow behind your head. Actually elevate the head of your bed with like some cinder blocks or something. You sleep on your side or your back, not on your stomach. A variety of diet modifications. There's a book called Dropping Acid that talks about this. It's a pretty good resource. So avoiding reflux triggers such as caffeine, spicy foods, alcohol, fatty foods or fried foods, eating smaller, more frequent meals. Hydration, but throughout the day, not just all at once. Avoiding tobacco, weight control, medical treatments, and then surgical treatment in some cases that are extreme cases. Unfortunately, the Nissen fundoplication has about a 50% fail rate, so it's not the go-to for treating reflux. And here is another exam. This was when I was having some reflux issues. Note the arytenoid redness here, and note the arytenoid redness and how much mucus there is back here. Note the arytenoid redness and the mucus.
Just a gentle E, like not you're speaking. One tone E. Christmas.
And I laughed because I gagged pretty bad. So, neurological voice disorders. These are problems or lesions in nervous tissue that is innervating the muscles of the larynx. So they can be at any level of innervation, so central or peripheral nervous system. Remember that the larynx is innervated by the vagus nerve, so CN10. The recurrent laryngeal nerve feeds all intrinsic muscles except the CT and subglottic sensation. And the superior laryngeal nerve feeds the motor for the CT and supraglottal sensation. Voice change may be the first presenting symptom of motor neuron disease, for example, amyotrophic lateral sclerosis. You might refer to a neurologist if you observe any weakness in their extremities, fasciculations in muscles, loss of sensation, or gait disturbances that are not explained by previous medical history. Actually, about a month ago, I was speaking with our physician's assistant at one of the skilled nursing facilities that I work at, and she mentioned that she noticed a change in a patient's voice, a dysphonia, and it was the first presenting symptom, and the patient turned out to have ALS. So this is indeed a real phenomenon. So your book provides a little summary here of vocal fold and palatal appearance as a result of brainstem or peripheral nerve damage. You can check this out. Upper motor neuron disorders. These include etiologies such as cortical and subcortical strokes, pseudobulbar and supranuclear palsy, and some presentations of ALS and MS. Most obvious vocal characteristics are roughness with a spastic and strained or strangled component. Patients with dominant hemisphere stroke and Broca's area can exhibit phonatory apraxia. They can be unable to initiate phonation or other non-speech laryngeal behavior volitionally, such as coughing and throat clearing. This is typically a transitory finding, and then the apraxia will evolve into verbal or nonverbal apraxia. With ALS, patients might have concerns of gradual onset of hoarseness that appears to be strained or strangled. And this, like I mentioned, can be a first sign of bulbar presentation in ALS. ALS patients might demonstrate abnormal acoustic measures. They might have a tremorous quality on sustained phonation tasks. Treatment is directed towards improving functioning of all systems involved in voice production. Speech exercise regimens have not shown to be effective in ALS patients, but the results are equivocal. In the early stages of intervention, ALS patients might be good candidates for message or speech banking systems that can eventually be incorporated with AAC. Amplification devices might be an option for increasing loudness. The primary goal is for the patient to produce more relaxed phonation and improved respiratory phonation coordination. Postural alterations can also be helpful in facilitating this. Multiple sclerosis is a disorder of demyelination of the white matter tracts in the brainstem, spinal cord, cerebellum, and paraventricular region. And it initially presents as Charcot's triangle, so nystagmus, kind of the eye movement disorder, dysarthric speech, and intention tremor. There can be changes in smell, vision, facial weakness, alterations in balance, hearing loss, and dysarthric speech. A hallmark of MS is recurring episodes of focal neurologic deficits that remit and recur, sometimes over relatively long periods of time. It typically presents between ages 20 and 40. It's more common in females. It's a progressive disease. It's diagnosed by MRI, showing evidence of demyelination or via spinal tap. And treatment is somatic speech, swallowing, voice, balance, etc. therapy to address whatever the deficits are. Myasthenia gravis is a neurological disorder characterized by fatigability of muscles with gradual return of muscle strength after use. So this is more predominant in males. Peak onset is about 60 to 70 years old. Dysphonia or dysarthria occurs in 6 to 25% of patients. The most common symptom is ptosis or eye droop. Other signs and symptoms are voice fatigue, so fatigue of the voice, the lips, the tongue, and the mouth. Diagnosis is made by a history of fatigue confirmed by a tensilon test, where the muscles are excited and then EMG is measured. And so it just shows fatigue of the muscles upon repeated electrical stimulation. And myasthenia gravis can be treated pharmacologically and occasionally surgically. So lower motor neuron disorders, this includes damage or disorders in the brainstem and peripheral nerves. Given mild unilateral paresis, the opposite vocal fold might be trained to compensate such that the dysphonia symptoms are relatively absent or minimal. So vocal fold immobility or paralysis is perceptually characterized by breathiness, roughness, and possibly diplophonia, so the presence of two simultaneous frequencies. So inspiratory stridor can signal the possibility of bilateral recurrent laryngeal nerve damage with near normal voice quality, but potential airway compromise. So in this case, the adductor muscles might function normally, but the abductor muscles don't. So this can be a pretty serious issue. So the patient might have dyspnea or air hunger with signs of exertion. So when one or both vocal folds are paralyzed in the abducted position, airway production is compromised, and there can be an increased risk of dysphagia and aspiration. Recurrent laryngeal nerve paresis or paralysis. So paresis is weakness or partial loss of muscle activity or movement, or partial paralysis. Paralysis is total loss of muscle activity or movement. So these can be temporary or permanent. They can be unilateral or bilateral. They can be caused by surgery, such as open heart surgery, thyroid surgery, cervical spine surgery, which can result in damage to the nerves feeding the larynx. They can manifest as breathiness, diplophonia, voice breaks, etc. This can also be caused by intubation injury or even viral infection. Differential diagnosis of paresis and paralysis versus joint fixation or dislocation is often done by EMG, like I mentioned previously. Treatment will likely involve trial voice therapy to attempt to improve medialization and vocal fold movement, and address the maladaptive phonatory behaviors, such as possible muscle tension dysphonia or ventricular vocal fold adduction. And if voice therapy does not improve the vocal fold mobility, then surgery might be considered. something like a vocal fold augmentation via injection, so autologous fat injection or Symetra injection, or possibly vocal fold medialization surgery, like a type 1 thyroplasty surgery might be considered. Extrapyramidal disorders include things such as Parkinson's disease and Huntington's chorea. Essential tremor is generally also thought to be an extrapyramidal disorder. Parkinson's disease, though, is the most common extrapyramidal disorder. So this manifests as hypokinetic dysarthria. So the speech is characterized by monopitch, reduced loudness, low pitch, mumbling, fast rushes of speech, things we discussed in the motor speech disorders section. And this is oftentimes addressed with LSVT loud for Parkinson's disease patients. So it capitalizes on the patient's intact voluntary control of loudness and pitch to improve intelligibility and overall speech production. So the concentrating on increasing the loudness of the voice. LSVT certification is required for SLPs. And one of the good things about LSVT therapy is that maintained effects of therapy have been demonstrated over time with many different studies. Huntington's chorea is a hyperkinetic dysarthria. Huntington's chorea manifests as a hyperkinetic dysarthria characterized by strained voice quality, and monopitch. So cerebellar disorders result from cerebellar damage, possibly due to a degenerative process or due to stroke. And they can be characterized by rough voice, fluctuations in loudness and pitch, discoordinated movements of the phonatory and respiratory systems. And treatment might be aimed at improving the timing of onset and phonatory respiratory coordination. Neuromuscular junction disorders include myasthenia gravis and others. These are characterized by a disturbance of the neuromuscular junction or the muscle itself. And the voice signs and symptoms are related to the site of the damage. With myasthenia gravis, this is a progressive hypophonia or weak voice, with voice becoming weaker over time with continued use. An assessment might involve a counting task, such as counting from 1 to 100, and the voice will gradually get weaker and deteriorate as the task progresses. Vocal exercises are not advised in these patients because their muscles get fatigued very quickly. They get weaker during the task. So exercise is not really helpful for these patients. Treatment is usually symptomatic. So laryngeal dystonia, formerly known as spasmodic dysphonia, it's likely caused by a dysfunction of the central nervous system. It possibly can be classified as an extrapyramidal disorder. Functional MRI studies show distinct alterations within the sensorimotor network. And laryngeal dystonia patients with a family history had distinct cortical and cerebellar abnormalities. So that might indicate that this is a central nervous system disorder. There are multiple types. So there's adductor type, abductor type, mixed, and a variety of other types. The most common is adductor, and this is characterized by strained or strangled voice with effortful speech. And then there's abductor type, which is characterized by episodes of breathiness and rapid air loss. It's more rare. And then there's a mixed type, which is kind of combined adductor-abductor type. Laryngeal dystonia will be evaluated via flexible endoscopy because the abductor muscles or the abductor muscle spasms will typically disappear during the sustained phonation that you'll evaluate with rigid endoscopy. So for abductor spasmodic dysphonia or laryngeal dystonia, you might do the 60s. So 61, 62, 63. So a patient with abductor spasmodic dysphonia or laryngeal dystonia might sound like 61, 62, 63. So there's a kind of a breathiness that happens during the onset. So they're not able to time voicing appropriately. The posterior cricoarytenoid muscle is activated when it shouldn't be. Adductor spasmodic dysphonia or laryngeal dystonia, you might look at the 80s. So 81, 82, 83, and that might manifest in an 80 spasmodic dysphonia or laryngeal dystonia patient as 81, 82, 83. So the initiation, the onset is kind of strained. Differential diagnosis of laryngeal dystonia versus muscle tension dysphonia psychogenic disorders versus essential tremor can be very difficult. And so you have to kind of observe the consistency and the patterns of tension. MTD, for example, might be constant tension. And so doing 60s or 80s or whatever, there's not going to be a differential pattern of tension. The tension is just there all the time, right? Versus spasmodic dysphonia, it's going to, or laryngeal dystonia, it's going to be kind of task specific. Laryngeal dystonia or spasmodic dysphonia is oftentimes treated with a voice therapy plus botulinum toxin injection. This provides monthly symptomatic release. Unfortunately, it has to be repeated on a monthly cycle with waxing and waning voice improvement over time. And there are some studies that indicate that voice therapy paired with Botox injection can help prolong the amount of time needed between injections. I've actually seen these procedures many times. The ENT will take the Botox needle and inject it through the cricothyroid membrane into the TA muscle from below for adductor spasmodic dysphonia, and into the posterior cricoretinoid muscle for abductor spasmodic dysphonia or laryngeal dystonia. And they use also laryngeal electromyography. And so they'll have the patient do for adductor, they might do an adduction task. For abductor, they might do an abduction task. And then you can hear via the feedback from the EMG, you can hear the action potentials of the nerves actually firing when those muscles contract. And so say, okay, I'm in the right spot for injection. I can now inject the Botox because I'm in the right muscle. So because you're kind of doing it, you're doing it via the feedback of the EMG. Interestingly enough, there are also pharmacological interventions that are being explored. For example, sodium oxybate for these laryngeal dystonia patients. There's some research by Simeon et al., and it's really amazing stuff that she and her colleagues have done. Malignant voice disorders, so cancer. Squamous cell carcinoma is the most common. There are precancerous conditions that require close monitoring, such as leukoplakia and dysplasia, so kind of abnormal cell tissue on the superior surface of the vocal fold, for example. Head laryngeal cancer is the most common type of head and neck cancer. It's 2 to 5% of all cancers. It can be glottic, subglottic, or supraglottic. Symptoms include hoarseness, stridor, throat pain, decreased frontal frequency, strain, and a globus sensation. Smoking and alcohol are primary risk factors. Lesion borders are irregular, which makes sense since cancer is uncontrolled cell growth. So you'd expect the borders to be irregular. And a treatment is some combination of surgery, radiation, and or chemotherapy, depending on the locus and the severity, the extent of the cancer. And speech language pathology's role in treating the cancer patient. So SLP therapy is secondary to and provided after surgery. So this can include things like counseling, management of sound production and swallowing methods, patient education. Given laryngectomy, it might be alaryngeal speech facilitation. If a person is hoarse for at least 2 weeks without knowing why, they need to see an otolaryngologist to rule out laryngeal cancer. So the irritable larynx. We'll start with PVFM, so paradoxical vocal fold motion, also known as vocal cord dysfunction, the older term. So PVFM is a vocal fold approximation during inhalation and abduction during exhalation. So this is not related to disease. So basically it's a contradictory or opposite movement pattern. Vocal folds normally abduct during inhalation, so they open, so your airway opens during inhalation, and there's typically a slight adduction during exhalation. So the movement pattern is opposite. Signs and symptoms include inspiratory stridor, a feeling of throat constriction, dyspnea, kind of hunger for air. PVFM patients are typically female, like young female athletes is kind of the typical patient profile. Up to 15% of athletes and military personnel with dyspnea upon exertion are diagnosed with PVFM. Diagnosis is typically given when all other possibilities for the behavior have been excluded, including asthma, structural airway obstruction, vocal dystonia, et cetera. So patients undergo pulmonary function testing, and then asymptomatic patients then undergo a methacholine challenge test, which can then help determine a diagnosis. A PVFM is associated with signs and symptoms of GERD and decreased laryngeal sensation. So you're going to want to determine what the conditions and the triggers are for the PVFM episodes. The diagnostic gold standard is transnasal endoscopy after a PVFM attack. has been elicited, so you can actually watch the abnormal movement. So the trigger might be inhalation of an irritant or exertion, like exercise-induced PVFM. And patients are often taught rescue breathing techniques, such as 3 quick inhalatory sniffs to give maximal vocal fold abduction, followed by a slow, easy exhalation through pursed lips or on an S. So, chronic cough. Chronic cough is cough not associated with lung disease, sinus disease, or upper respiratory tract infection. And it's diagnosed like PVFM when all other possibilities have been ruled out, such as asthma, exercise-induced asthma, upper respiratory infection, COPD, etc. So there is an association that's been proposed with GERD, but it hasn't been shown yet. Patients might be treated with cough suppressants for years. You might have to collaborate with, there might be collaboration with a pulmonologist or a respiratory therapist. There's also a chronic laryngospasm, which is an involuntary spasm or contraction of laryngeal muscles, not related to airway protection attempts during swallowing or some other neurologic disease. Now, treatments for PVFM and chronic cough include behavioral therapy, medication, and or psychological intervention. So SLPs will educate the patient in normal physiology, discuss triggers and their response to these triggers, provide some reassurance, and then establish a general relaxation response. The principle of behavioral therapy is to maintain continuous, slow, and paced quiet breathing and airflow with conscious attention and focus at the lips and or abdominal muscles. The goal is to shift the locus of control for managing the disorder from some external source like the odors or exercise to the patient, the respiratory retraining. So rescue breathing techniques are used as needed, as the rescue techniques that I just demonstrated. A hierarchy of least to most challenging situations is developed, allowing the patient to move from easy breathing at rest to maintaining airflow during exertion, emotionally challenging situations, and or exposure to laryngeal irritants, whatever the trigger might be. And it's critical that the patients practice these breathing techniques consistently on a daily basis to facilitate respiratory control and avoid relapse. And a referral for psychological intervention might be required when the patient doesn't respond to behavioral intervention. So voice disorders and professional voice users. Performers, professional voice users, people like singers, actors, they experience unique and difficult to manage problems related to voice use due to the fact that their lifestyle and livelihood are dependent upon the quality of their voices. And even minor alterations in their voices can have significant consequences in terms of lost jobs, lost income. Challenges include basically job required voice overuse due to the busy performing, recording, interviewing schedules that they have. Lifestyle choices might not be conducive to healthy vocal hygiene. They might perform late, eat late, maybe they might drink late, smoke, drug, substance abuse can be an issue, reflux, stress factors, frequent travel, other environmental exposure issues can all be challenges. Taking a thorough history is essential. So severity of the dysphonia, timing, onset, experience, training, lifestyle factors, timing of coming performances, medication lists, all of these things are essential. This requires a team approach, ENT, SLP, singing or acting voice specialist, and other medical professionals. And each will provide their particular assessment and contribution to the multidisciplinary evaluation. And so all of this information is then shared with all of the specialists, and then together as a team, they can collaborate and determine a best plan of care, a best course of action. What do you do if there's an acute illness before a performance? One has to weigh the risk. Is there a minimal risk with performing versus a possibility of permanent damage? Usually that's rare, but it can happen. Symptomatic treatments are oftentimes sufficient. So things like humidification, humidifiers, hydration, decongestants, mucolytics, good quality sleep, avoidance of drying agents, Possibly antibiotics and systematic steroids can be prescribed by the ENT if needed. There are chronic voice disorders that exist in performers. So this can be ameliorated with proper voice training and lifestyle modifications. Surgery is not usually indicated, but if it is, you would want an experienced laryngologist to perform it. As I mentioned, multidisciplinary team approach is essential. Pre and post-surgery voice therapy and reflux management are essential. And then if there is surgery, then gradual guided return to voice use. Okay, and treatment can be behavioral, medical or pharmacological, and surgical. I've said this before, but I'll say it again. If surgery is required, behavioral therapy must be undergone first so that phonotraumatic behavior is eliminated or minimized. If phonotraumatic behavior isn't addressed first, the patient will likely disrupt the healing process and/or will likely damage tissue following surgery. If the lesion is caused by the behavior, then the behavior must be addressed first, or the lesions will likely recur. After the evaluation, data is synthesized and you collaborate with the ENT to create a hypothesis regarding the cause of the voice disorder and then a plan of care to address the problem. So most voice disorders are multifactorial. Many signs and symptoms overlap across different patients, but the significance of each sign and symptom, the development and persistence of the voice disorder may be different. So you need to kind of determine and rank the significant contributing factors and behaviors. You need to prioritize various types of behavioral modifications. So voice misuse, overuse, or abuse. Determine which aspects can be addressed behaviorally and which ones might be needed to be addressed medically or surgically. Educate the patient about the disorder and vocal hygiene, and create concrete structured steps for increasing hydration or minimizing abusive behaviors, whatever needs to happen, in order to build awareness of behaviors that can gradually change the health status and lay the foundations for further therapy. And you might need to educate the patient about the process and the timeline of therapy and the expected changes. So, hygiene education. First, stay hydrated. I'm from Texas, and they used to say, pee pale, sing whale, because I kind of grew up as a singer. So you could say sing well or speak well. So monitor fluid intake. If you have clear colored urine, that means that you're drinking enough water. Carry water with you throughout the day. Try to sip small amounts frequently. You can replace diuretics like coffee and tea with water. And you'll need to drink more water if you're drinking drying medications or you're also drinking caffeine. And you set it up. It's not worth it for me to stop drinking coffee. I mean, I drink coffee myself, but I just know when I'm drinking coffee, you have to drink more water to compensate for it. Reducing vocal loudness as appropriate. So you might minimize background noise when you're speaking. No screaming or yelling. Reduce how much you're talking as appropriate. You might do some voice rest periodically. Pay attention to how you're talking. So speech should feel easy, low effort. Use plenty of air. Reduce throat clearing and coughing, which can be phonotraumatic. Limit smoke inhalation and exposure to irritants, and as well as exposure to allergens. Manage reflux, manage stress, and get good quality sleep. So relative to voice therapy, there can be facilitating techniques, also known as symptomatic approaches, that are designed to elicit improved vocal quality through modification of various aspects of vocal production. So techniques to change pitch or loudness or quality. And these can actually be used as a treatment probe to have the patient experience improved voice production in quick fashion. There's also physiologic approaches that are designed to modify the systems. So respiratory, phonatory, and resonatory systems. And so the assumption with this is that there's an alignment between the systems, there's an efficiency that has been offset by some type of aberration in one or more of the systems that's contributing to the voice disorder. So unilateral polyps, for example, disrupt the body cover motion of the vocal folds, resulting in incomplete closure that requires increased adduction or increased subglottal pressure to compensate. And supraglottal structures might also be affected. There's also a variety of named approaches, such as vocal function exercises, Lassac, Madsen, resonant voice therapy, stretch and flow, confidential voice. Many of these rely on semi-occluded vocal tract exercises, where there's a semi-occlusion of the vocal tract, such as lip trills, tongue trills, or raspberries. Voiced fricatives are also semi-occluded vocal tract exercises. So, or a phonation with a straw held between the lips, either in air or submerged in water at various depths. You can modulate the straw diameter to change airflow resistance as well. So these are all semi-occluded vocal tract exercises that increase airflow resistance in the oral cavity or at the lip in order to kind of balance sub and supraglottal pressures. So if you increase the pressure in the oral cavity, you're going to decrease transglottal pressure, and thus there might be less impact forces on the vocal folds. That's the idea anyway. So let's talk about a few specific exercise regimens. So vocal function exercises. This is a holistic physiologic therapy program used for hyperfunctional and hypofunctional voice disorders. And it's a systematic exercise regimen designed to elicit balanced coordination of laryngeal muscles. And there's 4 components. There's a warm-up, a stretching exercise, contracting exercise, and a low-impact power exercise. So you start with sustained phonation on E at a comfortable pitch, extremely soft with extreme forward focus, almost nasal. Then there's a stretching exercise. So ascending glide on an extremely closed O. So and then there's a contracting exercise, descending glide on extremely closed O. And then there's a maximum phonation task on an extremely closed O. On these particular pitches for males, and then an octave higher for females. Keeping the lips closed, the pharynx open, and awareness of frontal vibrations. And the pitch range can be customized as necessary. And you can also replace the superclosed O with lip or tongue trills as desired. So you produce all sounds as softly as possible. There's an emphasis on easy production. The tone should be forward on all tasks, almost, but not quite nasal. So there should be a sensation of vibration in the bony structures of your anterior face or your maxilla, kind of behind the nose, kind of a vibratory sensation. Avoid glottal onsets, pitch breaks, wavering of tone, breathiness, and unnecessary tension. Use good respiratory support. And the sequence is performed 2 times in a row, 2 times a day, morning and night, for generally 6 to 8 weeks. Resonant voice therapy, or Lassak-Madsen resonant voice therapy, is another type of holistic physiologic therapy program. It's typically used for hyper and hypofunctional voice disorders. And it's a generic name for therapies targeting sensations of forward focus or anterior oral vibrations during easy phonation. So resonant voice tends to be associated with barely touching vocal folds, which tend to optimize the relationship between large vocal intensity output and small vocal fold impact stress, and requires the least amount of subglottal pressure to initiate phonation. So there's a gradual progression from basic gestures to more ecological contexts. I should point out that I'm not resonant voice therapy certified. I'm just kind of discussing the generalities of the procedure. So it begins with a stretching of the body and breathing maneuvers. Then the basic gesture, sigh with extreme forward focus, breath awareness, and relaxation. And then step 1, all non-linguistic speech context. So ma, 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 ma. Experimenting with rate, ease, intensity, and pitch. Eventually, there's chant speech on carrier phrases such as Mary made me mad. And you might add voiceless consonants, mama, papa, mama, papa. Then adding the voiceless consonant requires rapid laryngeal articulation, which is more similar to running speech. So we're getting longer and more complex. Eventually, chant speech with voiceless consonants. Mom may put Paul on the moon. Then you might introduce novel phrases, maintaining forward focus, combine strings of phrases, begin carryover into conversation in novel environments, all the while maintaining this anterior forward focus. Maybe emotional manipulation, topics that elicit emotional response. And throughout this, there's home exercise, so 15 to 20 minutes a day, including the stretches, the basic gestures, and selected other steps as well. And one note on evidence-based practice in voice therapy. So evidence for much of voice therapy does not yet meet rigorous requirements for evidence-based therapy. However, as clinical measures of vocal function and patient-reported outcomes are validated and applied to programs of therapy, it's expected that the effectiveness and efficiency of appropriate voice therapy will be demonstrated over time. That being said, note that the three components of EBP are research, practitioner experience, and clinician preferences and values. But one has to understand what research means. So research certainly should mean that specific therapy approaches that you wish to consider have been studied, or that the problem that you face with your client gives rise to numerous therapy approaches that have been studied. So, however, in voice therapy, more important is that the research has explained the relationship among phonation production variables. That is, when you're confronted with a problem in voice therapy, what did the basic studies of phonation tell you about that and about how to change your client's phonatory behavior to improve production? So, for example, a functional case presents itself to you in which the person produces a high level of adduction, which appears to be associated with his hoarse voice and vocal fatigue symptoms. You wish to change the quality of his voice relative to adduction. You don't need a clinical study of the change of adduction to know that less adduction separates the arytenoid cartilages some, separates the vocal fold some, and reduces the impact forces on the vocal fold tissues if the subglottal pressures do not rise. And it also increases the flow through the airway because of less laryngeal flow resistance. And you don't need a clinical study to show that there will be more flow. This just follows from basic physiology and mechanics of phonation. So kind of a first principles approach. You know basic physiology and biomechanics of phonation. So therefore, because you know what the problem is, you can address it physiologically, right? There are a few other examples of this in the notes, and I urge you to read these. It is not the package itself in these kind of packaged therapies. It's what's inside the package that addresses the physiological reality, which should be addressed. So yes, these packaged therapies have been studied and they've shown improvements, but more important than the package itself is what's inside of it that addresses the physiological reality. So there are other treatment variables to consider. I've shown this slide before, but I'll show it again. So the duration of sessions, for example, or maybe at a more macro perspective, how long will they be on the caseload? How many times a week? So frequency, load dose. So how many reps and sets of various exercises? Intensity, how much effort per rep? What's the therapy sequence, the task order, the task progression, how fast to progress through different targets? Generalization, when are you going to target this? Like how practice on one target affects similar but untrained targets. Carryover or retention, performance level after practice is completed. So are they generalizing to untrained targets? Are they carrying over after therapy is done? You might have to address motivation, adherence, and compliance issues. So Stempel and Hapner did a good job of examining some methods for enhancing patient engagement and success. You can look at. Is there a need for booster therapy in the future to continue gains that were made previously in therapy? Here are some resources for learning more about voice and voice disorders. So conferences is one. The Voice Foundation has an annual symposium in Philadelphia every summer. I presented my dissertation research there this summer. There's the Fall Voice Conference, Pan American Vocology Association, or PAVA. That has a lot more singing type stuff in it as well. There's also NATS, National Association of the Teachers of Singing, which if you're interested in singing. There's a Voice Therapy Conference, ICVPB, so International Conference on Voice Physiology and Biomechanics, AQL, Advances in Quantitative Laryngology. There's, of course, the ASHA-SIG 3 Voice and Voice Disorders Group. There's various courses in specific treatment methodologies, such as LSVT and resonant voice therapy. There's courses in video stroboscopy. There's centers for voice observation. There are clinical training voice CFYs, like Pinta and Philadelphia, Emory, Vanderbilt, although these are highly competitive. There's other training. So NCVS has a Summer Vocology Institute they might check out. And there's obviously a variety of textbooks and journal articles. So check these out. And I would like to share with you this link to this short documentary called Voice Journey. This focuses on my old boss, Robert Sadloff in Philadelphia, and he treats a few patients. And this is a very interesting watch if you so desire. So, well, that concludes this lecture. And thank you so much for watching. I'll see you next time.